So here, so we are coming back to the topic for today, which is about rehabilitation services management, or how to manage rehabilitation services. So the background we laid was for us to understand public health, broadly speaking, and then we zeroed in on epidemiology. What is epidemiology and implications for us? And then we have discussed epidemiological transitions, and where we are emphasizing that, yes, we have a double, or what we call a dual burden of communicable and non-communicable diseases in our country, and it's pretty much a major challenge these days. So I guess in our clinics, we see more people with hypertension or people who have stroke and all of that. So now if we are to deal with this topic of, I wanted to introduce us to some concepts that we use in public health or in planning public health or population health programs. So if you realize, I'm not trying to focus only on clinical aspects because we are all familiar with it's what we do every day. But I wanted us to see planning and managing rehabilitation services from a framework that WHO developed with several others some years back. It's called Service Availability and Readiness Assessment. We call it SARA. Now, what happens is that, so if, for instance, in Nigeria, we look at the highest disease burden. So we have high infant mortality, high maternal mortality, and malaria, and all of that before coming to rehab. So you want to say, okay, look, how do I provide these services to the population? What do I need? So there's this questionnaire, a framework for trying to find out if you are ready to deliver that service. So for instance, this tool, as we call it, SARA, that's Service Availability and Readiness Assessment, is a health facility assessment tool which is designed to help us assess and monitor the availability of a particular service and the readiness of the health sector. And then through that, we generate evidence that will support the planning and managing of that health system ability to provide the service, just to make it easy. So if, for instance, we go to a primary health care center, and so there have been in recent times, so all of us know that last year, WHO passed a resolution, or World Health Assembly rather, passed a resolution encouraging countries to ensure that they strengthen the systems for delivering rehabilitation services. It's like a landmark resolution, because for the first time, rehabilitation has received a kind of global attention that it deserves. So during the MDG days from the year 2000 to 2015, rehabilitation did not appear in the global health agenda. And then we started these Sustainable Development Goals, and rehabilitation was mentioned as one of the services to be provided as part of providing universal health coverage, so the definition of universal health coverage is that everyone, irrespective of their socioeconomic status or where they live, should be able to access and receive the kind of services, health services that they require at that time, whether it's promotive, curative, rehabilitative, or rehabilitative services. But most countries have never prioritized rehabilitation services. So this is the first time WHO, World Health Assembly. World Health Assembly is the equivalent of our National Council on Health. It's the highest policy-making body for health in the world. So WHO is the secretariat. So every year, usually in May every year, all the ministers of health and top people from each ministry, each country, will be in Geneva, the headquarters of WHO, for about a week. So they discuss and pass resolutions, just like it's an arm of United Nations. So we have the United Nations General Assembly. So for health, WHO coordinates that. That's the World Health Assembly. So for the first time, they passed a resolution that focused on rehabilitation, which is good. So, and it's part of advocacy through the Rehabilitation 2030 agenda. I guess some of us are aware of that. So coming from that, having laid that foundation, so when you want to now say, okay, how do I measure service availability? So service availability measures and assesses the extent to which specific services are offered and available in the relevant healthcare setting. And then with respect to readiness, readiness speaks to whether those facilities have the necessary staff, they have the framework like guidelines or guidance on how to provide those services. So I don't know whether we know about standard operating procedures or protocols or treatment protocols called SOPs or SOTs. So do they have the right equipment? Do they have the right diagnostics? Do they have the right medicines and commodities to deliver those services? So yeah, so that's pretty much what service availability and readiness is about. So before we go ahead, so I would like to pose a question. So if we, in a primary healthcare center, currently, most primary health centers don't have a rehabilitation expert there. So if we are to recommend to government to start providing primary health, whether physiotherapy or rehab, any aspect of rehab services at the primary health care, I would like us to use this broad framework to maybe what are the key things that we need to take into consideration. Somebody, you can speak to issues of staff or guideline or equipment and all. So maybe one or two people can let us know what type of staff should we have at the primary healthcare center. Maybe I'm not speaking, maybe even in an urban area where we may have like specialists in rehabilitation that can provide those services. Maybe somebody can just quickly tell us, or you can type in the chat box how we can go about that. Anyone speaking? Hello, are you trying to speak? Hello? Okay, maybe I'll continue. All right, so I mean, this page will help us, or this slide. So when we are trying to measure service availability, so there's what we call tracer indicators. So in public health, when we want to count, for instance, like when you want to monitor specific things, we talk about indicators. Maybe in broad research, they might be called variables, for instance. So if I want to, so in public health, when we want to measure to see what is the impact of what we are doing or when we are collecting, so we will usually use what we call indicators or specific ones, maybe will now be called tracer indicators. So for instance, for service availability, there are 3 broad trace indicators that is used generally. We've been based on the framework that WHO developed, that is for service availability and readiness assessment. So first of all, it looks at the health infrastructure. So under this health infrastructure, it will look at if we are looking at a particular facility, we'll look at the population density of that area. And so if, for instance, in a particular location, their population is about a particular number, maybe X number, and then a certain number of outpatients go to that facility. So you're using the denominator as that population catchment area, and then the number of outpatients that are going to that. So maybe, for instance, a primary healthcare center in a locality. So using that facility density per population, 10,000 population gives us an idea. So it gives us a number. And then we also check the inpatient bed density. So under inpatient bed density, WHO would advise we should not include maternity beds. That's because the third tracer indicator is for maternity bed. This is under health infrastructure. So it looks at every other thing, but I'm just using this as an example. So it's a very big document, but I just pulled out some of this so that you give just like an idea when we are measuring or when we are looking at service availability. Then the next one is the health workforce. So it also looks at the density of the core medical professionals per 10,000 of the population. So for instance, maybe looking at the number of physicians that is, how many physicians are providing care to this population density. So if it is 100,000, so now how many physicians ideally will provide that service? So WHO has specific numbers or ratios. So, okay, this number of healthcare workers should provide services to this population. So includes non-physician clinicians, as is mentioned. So I included there in bracket rehabilitation experts, nurses, midwives, and it also says that it also includes part-time physicians. Not in some places, you have people who are working full-time somewhere, but they provide part-time services to others. Then under service utilization, so sorry, there are just three: health infrastructure, health workforce, service utilization. We'll go into more details. Okay, sorry. Okay. So let's take, for example, in terms of readiness. So in terms of readiness, so at a health facility, we will look at the power. That is, according to WHO, we look at the power. Do they have steady power? What is the source of the power? Is it through generator, or is it through the national grid, or are they using alternative source of energy like solar for them? So this is critical. Why this is important is, for instance, if we are looking at availability and readiness for immunization services, you realize that power is critical because vaccines are very temperature sensitive. So a health facility should have their cold chain should be intact. So they should have freezers that are working because we need to store the vaccine antigens in specific temperature because they are sensitive to heat. So a health facility that doesn't have any regular source of power, obviously they will not be, we wouldn't consider them ready to be able to provide vaccination services. For instance, if as physiotherapists, we are working in a place where, let's say in the community, and somebody has an injury, maybe they dislocate their shoulder or have any ankle soft tissue problem, we know that at that acute phase, we need ice therapy. So if a health facility, a primary health center, maybe we have someone working there and they don't have power for having at least making ice or storing ice, providing the kind of care at that acute phase, that facility might not be able to provide that optimally. So these are some of the listed, I just put some of them from what WHO says. So improved water source insight. So they should have a regular source of water because it has implications for their sanitation. And also inside the health facility or in our departments, do we have a room that provides the type of privacy, both auditory and visual privacy for the patient? So the patient's privacy is critical if we are to provide services for them. I've mentioned sanitation, communication equipment, phone. Do they have facilities for, do they have computer? Because these days we store health records in digital forms or transmit them in digital form. So increasingly having a computer or a digital device in a health center or a health facility is critical. Then this other one, in terms of emergency transport. So if there is emergency, maybe a woman is in labor and there is maybe breach and they need to be referred to a secondary facility for either emergency CS. Do they have the facility? Do they have access? Do they have, emergency transport, whether ambulance or any type of ambulance, to transmit the person from that center to another center? So these are some key things about basic amenities. And then in terms of equipment, it has also specifications. So if we are to provide a specific service, maybe occupational therapy service for someone who has stroke, there are specific type of equipment that we will need, or modalities that we need for treating that person or managing that case. So diagnostic, essential medicines. I mean, because we are not dealing really with medicines, but of course there are some medicines like pain. There are some medicines that we provide in when we are treating, especially cases of musculoskeletal diseases, like osteoarthritis. We use also some types of medicines, even though they are applied maybe topically or through electrical devices. So these are some of the things. I'm just using this broadly. So this is just highlight of how, if we are to plan for health rehabilitation services, first we need to do an assessment. Is this facility ready? And do they have the capacity to provide this particular service? So in trying to arrive at that, we have to look at different dimensions and all. So I think we will pause here. So one thing I want to ask is, I know that the MRTB would usually do assessment of health facilities. Maybe, for instance, for a particular health facility or hospital or department to accept interns, they need to be accredited. So see that as a way of an application of service availability and readiness assessment. So just to bring it down home. So what I would like us to do now, maybe in the next, say, 5 minutes, so I want all of us to reflect in our department, when we are to get or accept accreditation team from MRTB, what are the things that they will normally look out for? So that's just bringing it home. So in terms of basic amenities or basic equipment, what are the equipment requirements for providing rehabilitation services in any department? So maybe somebody can unmute their mic and just run us through, or we can use the chatbot. But I would like someone, a physiotherapist, to run us through, an occupational therapist to also share with us, speech therapists, just walk us through what are the basic requirements in terms of manpower, in terms of equipment, and in your facility, what are the things that MRTB would normally look out for when the team is coming for assessment or accreditation? Hello? Yeah, please, somebody can unmute. Yes, please go ahead and speak.
Yes. Hello, are you hearing me?
Yes, I can hear you.
Hello. Yes, I'm Akade Olutunmise speaking from Ogbomoso. Anytime there is need for accreditation, anytime MRTP comes for accreditation, one of their major requirements is the facility in terms of physical structure, power, lighting is very important because a number of our patients are aged and they may have, not that they really have a visual challenge, but the department must be adequately licensed. Then, in terms of personnel, physiotherapists are the ones that must be available. Certain numbers of the There are certain number of physiotherapists that must be on ground, licensed by the board, having current license. And besides that, hello. Besides that, when we have a gym, there is specification for our gym to be wooden. That is, the floor must be wood, not the tiles. Number one, so that the patient, in case of any fall, the impact will not be disastrous. That's one of the specifications. In terms of equipment, equipment-wise, we should have what we call treatment tray. We must have treatment tray. We must have, in the area of socializations, we have something we call electrotherapy. In electrotherapy, physiotherapists inside the house, you understand what I mean. Like we have the deep heat modalities like shortwave diathermy, like microwave. We have the one like hot pack. We have the one that is most common. In the primary care center you mentioned, they may not be able to afford that, but at least they should have infrared, they should have TENS. And a number of times, physiotherapy involves exercises because we are exercise experts. We have the right of exercise, not that one for the physical and mental education. The physiotherapists in the house understand that we have the right of exercise equipment for strengthening, for flexibility training, for balance training, for coordination. And in neurophysiotherapy, there are certain things that we would like to have. Mental exercise mat. We have our bicycle ergometer, our treadmill, our treadmill, cross trainer, so many things. The one for cardiopulmonary endurance training, they will look at exercise equipment. And more majorly, MRTB is interested in area of specialization. See that each unit at a level of our department, I'm talking about teaching or teaching environment now, but adapting it to primary healthcare center that we are using as a case study, they may not be able to go into specialization. But no matter how, a physiotherapy department must have a spacious exercise gym area. There are two types of gym area that we need in physiotherapy. We have rehabilitation exercise gym, and then we have health promotion exercise gym. The health promotion exercise gym is the one that is meant for people who are apparently healthy, but either they want to reduce their weight, they want to keep fit, they want to build strength, or we want to change flexibility. But rehabilitation exercise gym is the one for rehabilitation in terms of whether you want to do strengthening exercises, balance training, we have the targets. Yeah. So I will not take your time. These are the few things I want to say about physiotherapy, a requirement by MRTB for accreditation.
Thank you so much. That was very, very extensive. And okay, Izu, I see. Hello, Izuchukwu. I know you just dropped something. Can you walk us through, because you mentioned some interesting, there are some things that you mentioned, for instance, call rooms, record and file office. Yes, this is really important. So we'll come to that health management information system later. Okay, he talked, yes, about gym, also license, exactly. So are the physiotherapists or are they licensed? Do they renew their license? You know, those are very critical because you want to make sure that the human resource is adequate for providing that service? Are they doing their continuous professional development? Are they meeting their CPD points each year to be able to renew their registration? Those are really, really important. So I know that we have a speech therapist here. Please, Ma, can you walk us through, like, what are the basic things that are needed for a facility to be able to provide speech and audiology services to clients in their facility? The speech therapist that spoke earlier, can you just, maybe in the next few minutes, walk us through so that we all understand what are in accrediting a place to provide speech therapy services or audiology services, what are the basic things that are needed to be able to optimally provide the service?
All right, sir. This is Chibungozi from
Thank
Port
you.
Harcourt.
Please go ahead, ma'am.
All right. The speech in a facility where patients will be sent for management. The readiness there is there should be a qualified speech therapist who is licensed and just like I work in the ENT department, the team management there is that when patients are referred from COPD, maybe the ENT surgeon sees first and then refer to the speech therapist. So the speech therapist must be qualified and be competent in handling the patient to be able to diagnose the kind of condition and provide the necessary therapeutic measure. And then some of the patients, like the stroke patients, on the side that's maybe having numbness or weakness, most times some of them come down with unilateral hearing loss. And if this is the case, we should be able to have a geometric machine and an audiologist who will be able to assess this patient when we are addressing the patient. Is the patient hearing or not? In some cases, somebody may have the better ear, and then the affected side is now where the better ear is. That means that there will be no hearing. And when the threshold of hearing is established, you'll be able to go along with the patient that this patient, when I'm talking to this patient, the patient should be able to understand me in terms of hearing. Then the levels of patients that are not yet fit for speech therapy who is not stable should not be referred to speech therapy. Therefore, the speech therapist should be able to know when patient is set.
Hello, can we hear her? I don't know whether is my network.
I think
Okay.
Good morning. Can you hear me, please? Good morning.
Okay, go ahead.
My name is Akiyemi Oyindamola. I'm a clinical audiologist. Please, I want to get your question right, sir.
Yeah, so the question is, within the concept of service availability and readiness, so what are the critical things that are needed within a health facility or an audiology department to be able to provide optimal services? So basic equipment needed, the type of human resource that is needed to provide that kind of service that the patient will require.
Okay, let me just run through the aspects of audiology very briefly for you.
Okay, please go ahead. Yeah.
Okay, so for audiology, one of the basic things that is required is a licensed personnel, a licensed audiologist by the Medical Rehabilitation Board, and is up to date with every licensing requirement to practice. Must possess the educational qualification definitely before you are licensed, and then you have your license with MRT. Then there are basic audiological services that can be rendered, and there are upgraded, or let me say, as you have said, for an audiological services to run extensively and provide optimal services. So for an audiological clinic, it's important to have a room where the audiology procedures are going to be carried out. The room has to be soundproofed in a way to reduce the noise level, as the assessment that will be carried out needs a room whereby the sound level is reduced. That's the basic, that's the one of the very first thing that has to be considered if one has to get a clinic in a facility. So after having a soundproof room, we'll also now be talking about the machines. So basically, the most popular one is the audiometer. Can you hear me?
Go ahead, we can hear you. We can hear you.
So the audiometer is required. Having an audiometer is required. If a facility wants to provide an optimal service in being able to provide services for all age range, because definitely audiometry is not for everybody. Children cannot, not all children. There is an age range for children who can do audiometry, and there are some children who cannot. So you will be requiring that, okay, such facilities will have audiological equipment that can assess hearing for children. Then we'll be talking about the autoacoustic machines, and we'll be talking about the AEP machines, that's the auditory evoked potential machines, where we have the ABR and the ASSR. Also, in an audiological clinic, if a facility is optimal and at its best provision of services, we could have where mold, impression taking is carried out. Some of those things are also available in some facilities and institutions, but basically for accreditation purposes, the basic thing is to have a personnel, have a room which is in requirements with a standard room for assessing audiological assessment in terms of the noise level in that room. So that room has to be soundproof, or you have a soundproof booth, or there's a soundproof booth where the test is carried out. Then the machines, like I have listed, basically. That's it.
Thank you so much. So you could see that why making this interactive is that because we are all under the same board, and this is an MRTB course or lecture it's important that other professionals know what each other is doing because we are part of the same rehabilitation team. So we've heard from the physiotherapists, we've heard from the speech therapists and audiologists. I think we also have an occupation, I believe we have an occupational therapist, possibly. If we do, please can you raise your hand or unmute your mic and speak and share with us what are the basic requirements for a facility to be considered ready to provide occupational therapy services. Any occupational therapists in the room, please feel free. There is no right or wrong. We just want to learn. It's more like learning and sharing together.
Hello, good morning.
Good morning. Please go ahead, introduce yourself. Tell us where you work. And yeah,
my name is Ibuko.
Sorry?
My name is Ibuko. My name is Ibuko. Yes.
Are you related to our registrar, Professor Woye? Former registrar of the board. I'm just joking. It's all right.
I'm
go ahead.
So I'm working with West Part of the Therapy Awareness Limited. Situated in Victoria. So when they came for accreditation, I can remember vividly that I've been under that twice. So the very first time they came, the first question they asked was my license, and I was able to present my license to them. That was number one. And two, I was asked to show them the equipment we're having. So I showed it to them, the use, what we use them for, why do we have to do that? You know, normally if you are attending to any patient, you must have done assessment to know the need of that patient, and then whatever activity you are, giving to that patient must match the need of that patient. So those questions were asked when I was putting them the equipment we have in the facility. Okay, this is what we do and that. So after all of that, the next question was, okay, was there any time you're doing the work of physio? Because that matters too. You can't be in a facility where you are doing jack of all trades. You are doing the work of physio, doing the work of OT, doing the work of speech therapists, the work of behavioral therapists and all that. So I was asked, was there any time, these are the little things that we overlook, but they matter too. And when people are being asked, they tend to say, like, they're trying to, put my integrity into check, but they matter, which I also appreciate. So I was asked that question, and I was able to tell them, okay, no, my work is strictly as an occupational therapist, which I've always been doing. And I like the fact that, equipment, also the part of equipment, this was the therapeutic value of this thing. Why are you doing this to that patient? I think those were the things I was asked though. Well, they started from which school did you finish from, then the license you're practicing with, is it the renewed or the old one? I was asked to present my license, of which they saw it, and then, from there they proceeded with the questions they were asking. So that's basically, this is the occupational therapist and new school meaning physiotherapy.
Okay, please, just for the awareness and knowledge, so that we all get to learn something new today. So what are the key equipment that you will expect to have in an occupational therapy department or facility?
Okay, now ADL kit.
Please just mention the full name so that people, not everybody here will know. Yeah, so just tell us the full name, what the equipment you use, just for our understanding and knowledge. Yes.
Okay, activities of daily living kit. There's a kit for that. That kit comes with the PD, when you want to modify the place of the patient. Some patients will get movement and they want to carry out PD. Some are foot can just dance in the place and then go out to the place. So in that kit, we have plate guard, we have bits of handled spoons, we have bits of handled cup, we have long-handled richer, we have long-handled sponge, we have, and so many of them. I don't know if you get my point, sir. So we have a lot of kits, a lot of things in that kit that help address activities of daily living. with patients that, that are declining.
Thank you so much. Thank you so much.
Welcome.
Yeah, so because what I know that we don't have as many occupational therapists like we have for as many in physiotherapy departments. Recently, just about 2 months ago, I visited a health facility, a hospital, one of the top in Sao Paulo, and I entered the occupational therapy unit. It was part of, so they have a rehabilitation center within the hospital. So we have physiotherapies, all the different equipment for different types of patients, for musculoskeletal disorders, for neurological, for pediatric, for geriatric, all sorts. So depending on the type of, depending on the disease or condition, you have specific type of equipment or facilities, either within a gym that is used for different rehabilitation services. So I also visited the occupational therapy one. It was quite big, like very, very big. I was really, really impressed. So that was why I was asking, because when I studied, we didn't have any occupational therapy around. So all the while I practiced, whether it was in Ibobi or the teaching hospital, we didn't have occupational therapists then. So that's why I know it's IFE, maybe other schools have started producing occupational therapy. So thank you for that. I think, I don't know if we have anybody has any question, or we could just take a short break. Okay, madam, when are we going to take a break? Let me keep that in mind to know how fast I can be. We are going to the next section that speaks to policy.
There is a hand raised up, sir.
Okay, please. Okay. Yeah, please go ahead and ask your question.
Thank you very much for the session. But please, before we go on break, I would like to mention that I'm sorry I missed the part where the requirement for speech therapy clinic was mentioned. Please, if the information can be maybe posted at the chat section, so I can read it.
Oh, great, that's helpful. So the madam that was giving us that answered with respect to speech therapy and audiology, please, it would be helpful if you can use the chat box and type out some of the key basic equipment needed and all of that so that we can all benefit.
Hello, sir.
Okay, go ahead.
Yeah, I'm sorry, my network went bad, so I couldn't.
Okay, you can just quickly run through it. Yeah, maybe in the next minute. Yeah.
In the speech therapy room, I mentioned there must be a licensed and qualified speech therapist who should attend to the patient. Now, in the speech therapy rooms, of course, you have your seats for the therapist, also for the patient and the patient relation. Okay. Then some of the materials we use, we have audio videos, we have charts, then different types of puzzles, flashcards. Hello? Hello?
Yeah, we can hear you. We can hear you.
Am I communicating? Okay, so we have child-friendly corner. We have toys of different types. You can have models, some of the common things we use in the house, like plates, cups, spoon, cutleries, the plastic types, so that a child that you're trying to teach a particular object, it has to be concretized. The child sees it in picture form or in a concrete form. So all these things are part of the things we have in the speech therapy room. And also, a speech therapist should also have a audiometer, because there are some patients that you need to, filled with sounds. Also, talk about, the child that was born congenitally deaf. They are out of, any form of sound. Before you start to bring that patient to the level of speech sounds, you have to introduce gross sounds and all sorts of sounds to be able to form a kind of sound sense into such a patient. So we have also storybooks. There are some of them you have to sit down and then, hello?
Yeah,
Hello?
please go ahead. Yeah, go ahead. Please,
So,
let's mute our minds, please, if we are not speaking. Madam, continue, please.
Okay, the speech therapy room has to be, splashy in a way that when patients are inside, they will feel at home, and then your personality also matters a lot, in attending to your patients. Now, I don't know if I've been able to give some of the areas, the one that is asking the question. I know, yes, I wasn't able to bring up this aspect of it when I was cut off because of network.
All right, thank you so much.
Thank you very much, ma. Thank you, sir.
Yeah. Okay, madam. Yeah, I was just asking, when are we supposed to go on break, and for how long, so that I will know when we can have a pause.
Okay, we can go on break now and resume back by 12 o'clock. Please, everyone should please kindly mute your mic. Lotan, I've been muting you since. And you keep on muting.
Okay, so it's 11:30 now. Okay, 11:38. So is that the only break we'll go? I just want to be sure so that we know.
Yes, please, sir.
Okay, that's the only break. Okay. Or should we continue till 12 and then have the break by 12? If you want us to go on, because we started by...
It's just short, so
okay.
If we have to do anything from now to 12, it's already very short, so you may not take a lot.
Okay,
yes,
so
sir.
we should take a quick break, maybe go grab some water or coffee.
Exactly.
Don't go and eat amala or akpu because they may want to sleep. So grab some coffee, go health break, grab some fruits, stretch a bit, and then by 12 we'll come back. So when we come back, we'll be discussing a bit from the perspective of policy, rehab-related policy, and I will update you on some current happenings within the policy space in the health sector. So let's have our break now. Thank you. So we'll be back by 12 noon on the dot. Thank you.
It's 12 now, and we are all welcome back from our short break. So, sir, you can continue with your presentation, sir. Thank you, sir.
All right, can you all see my screen now?
Yes, we can, sir.
Thank you. So welcome back from the break, and for the next, say, 20 minutes, we'll look at so we have looked, just to recap what we did earlier on, we started with public health, what is public health, and then trying to situate the role we play within the framework of public health from the perspective of health promotion, prevention of diseases. We may not be involved in epidemiology response to epidemics like COVID, but it's not as if we cannot be involved. So it's possible that we have physiotherapists and rehabilitation experts who have a master's in public health, or they did their own master's in field epidemiology. So field epidemiology, they are the ones who, for instance, during COVID or earlier on when we had Ebola crisis, so they did what we call contact tracing. So if you recall, with respect to epidemiology, we try to find out what is the causative agent responsible for this disease and how does it move from one person to another. So that is pretty much what epidemiologists will do. So during COVID, I'm using that as an example. I should have used that earlier on. If you recall, the index case is like the first case of COVID we had in Nigeria was someone who came in from outside Nigeria. I think it was from France, if I'm not mistaken. So this was 2020, I think February or early March that we recorded. Yeah, it was in February. We recorded the first case. So now contact tracing involved trying to find out who did this person meet physically, had a contact when the person landed in Nigeria at the airport. And then if you recall then, one of the ways to manage that was we had to isolate people who we suspect or have confirmed that they had COVID. So anybody who had any type of social contact with them, they had to isolate because there's a period an agent will breed and then manifest. So the people who did a lot of the contact tracing, using like a social network analysis or map, and they keep checking this person must have contacted this person, and they just went around to make sure that every particular person who may have remotely or directly had contact with that index case was identified. So as part of ways to kind of control the spread of that particular disease. So in a sense, pretty much, so epidemiology, we laid that foundation. And we also try to say that epidemiology is not only about infectious diseases. So we also apply epidemiology when we are studying non-communicable diseases. So for instance, they say low back pain. So we want to find out what is the frequency, like when we say the incidence or the prevalence of low back pain or musculoskeletal diseases, broadly speaking. So what are the etiological causes of such disease? So for instance, low back pain for physiotherapists and occupational therapists, we know that there are specific things, maybe long sitting, or if we are not observing the optimal ergonomics in terms of the chair we sit, our workstation, how we carry out our activities of daily living, how do we lift objects? All of those things are factors that would be classified as part of the etiology. Of course, some are idiopathic, as in we may not know exactly what is causing that. So in a sense, we also apply epidemiology in non-communicable diseases, in environmental health, where people are checking what is the air pollution issues, because it has to speak to, if you recall, all those top 10 diseases that we said they are leading, like chronic obstructive pulmonary disorders, infectious diseases, chest-related conditions, because clean air is critical, is an important thing. And then we talked about disasters and injuries. If you notice, because of climate change and stuff, we are having wildfires in places like Australia, Europe. Last year, I think Greece experienced wildfires burning up everywhere in specific islands. Australia, California experiences that. Even the Amazon in Brazil, which is like the largest area where we have tropical forests, they experience, because there's been some drought in some parts of northeast of Brazil, where Amazon is. So they're experiencing forest fires as well. So we have flooding due to climate change. Maiduguri was flooded, I think, last month. We know the disaster and the health implications. So infectious diseases will, because of poor lack of drinking water or pollution of the environment and all. So people will contract diseases and stuff. So that's epidemiology. And then we talked about the epidemiological transitions and the implications for us as rehabilitation therapists. Then we discussed the service availability and readiness assessment. I just provided the broad framework, and then physiotherapists, occupational therapists, audiologists, and speech therapists also shared with us what it would take to provide such services. So that's more like the practical application of that concept of service availability and readiness assessment. So normally, before I come to the policy side, so when using that kind of questionnaire so like I said, this is very detailed questionnaire. So within public health, if a program is to be delivered, for instance, I don't know whether some of us knew what the Midwife Services Scheme, MSS, or Shopee. Maybe Shopee will be much more popular. Do we remember Shopee during President Goodluck's time? Hello? Maybe you can do thumbs up. Shopee, that's subsidy removal and reinvestment program. So during that period, I can just run through, for instance. So because Nigeria is experiencing high maternal mortality and child mortality, so the government was thinking of what initiative can we put in place to address the high burden of maternal morbidity and mortality. So one of the key things that was observed was that, just to give you guys an overview, so women should normally go for antenatal services. They should go for antenatal. And ideally, we should have, at least within that 9 months of pregnancy, a pregnant woman should go to ANC, either at the primary healthcare center, basically at least 4 times, minimum of 4 times. Of course, it has been increased now, but at least the minimum is 4 visits. So, and then during those visits, they are supposed to be attended to by what we call skilled birth attendant. Skilled birth attendant. So skilled birth is that someone who has the proficiency to provide care to a pregnant woman and be able to deliver when they are in labor at a health facility. So one of the indicators for measuring health outcomes with respect to maternal and child health is, one, visitation did the woman complete 4 times of antenatal visits? And then there are also other things that happen for, at least we have women here who obviously have kids. Remember, when you go for antenatal, there are things that the nurse will check, a lot of things, and then they also provide health education, how to take care of your child, things you're not supposed to take. You're not supposed to take drugs, medicines without a doctor's permission or for one to take that. And then more importantly is that when pregnancy is due, the lady delivery should be in a health facility and attended to by a skilled birth attendant. So when Nigeria did all of that assessment and review, it was found out that majority of women who experience complications or who die, oftentimes they either die at home because they are delivering at home, or they are being attended to by like, the traditional birth attendants, we call them TBAs, like those old mama and sometimes some men who over the years, but some of these people are not educated, so they don't understand. They may not be able to pick up like danger signs that will make them say, okay, look, we need to refer. So when pregnancy is complicated or during delivery and there's some complication, for instance, there's breech presentation of the baby, it requires emergency CS, for instance, cesarean section. So from Nigeria to now make sure that we are providing optimal antenatal services and also delivery services. So the government, after all the assessment, realized that, for instance, the National Primary Healthcare Development Agency, it has some specific guidelines on what is the ideal, I'm using ideal number of staff and type that you should have in a primary healthcare center. So for instance, for a primary healthcare center to be qualified to provide delivery services, NPHCDA, that's the National Primary Healthcare Development Agency, expects them to have at least 4 nurses or midwives who are trained and competent to be able to help a woman who is pregnant to deliver their baby. So and then you have the choose. So majority of the primary healthcare centers, especially in the North, didn't really have nurses or midwives. So the government, as part of its initiative now, designed the midwife services scheme, which later was transitioned to SHOPI, the subsidy investment program, the maternal and child health component. So that project, the idea was, let's employ midwives. Majority were employed from the South, and they were posted to the North, to states and to health facilities that didn't have nurses or midwives. And they were provided the right kind of equipment to make sure that every woman so there's something they call Mama Kit. Mama Kit is like a pregnancy kit where it has all the essential things a woman needs when she's in labor. So the government provided all of that, and the federal government and state governments, we are partnering to pay for those midwives. And unfortunately, from the perspective of financing, they couldn't sustain that program. And then when President Buhari came, that project, that midwife services scheme, SHOPI, was phased out. So, I mean, why I'm laying that foundation is to come to the point of policy. So for rehab, it's important that we pay attention to policy developments at the federal or state level that have implications for our work. So that brings us to this next section. Since you know that last year we had a new government, so President Bola Ahmed Tinubu has what we call the Renewed Hope Agenda, or Renewed Hope Agenda. So for health, we have the health specific component. There's some things he wants to achieve in the health sector. So Now comes Dr. Pate, Mohammed Pate, who was former Minister of State for Health under Goodluck Jonathan's regime and has now been appointed. He was now appointed in July, August, I think August, as the new Minister of Health. So when he came in, he started envisioning a new program or a new health agenda. Previously, we had the 2016 National Health Policy, and then from that policy, we have what we call the National Strategic Health Development Plan. In short, we abbreviate it as NSHDP, National NSHDP, yes, National Strategic Health Development Plan. So when you have a policy, you need to have a strategy and a plan for its implementation within the framework of public policy. So if we are to have, currently we don't have a rehabilitation policy. So, so that's partly why rehab is not receiving the level of attention it deserves. But we'll come to some point to discuss what the MRTB, in collaboration with other key actors, is trying to do that. So this is what is happening. So I'm laying this foundation so that we know that we are in a new era. So there's ongoing policy conversations, and there's already a new health policy that will be adopted. So next month, by second week of November, the National Council on Health, NCH as it's called, NCH, otherwise called the National Council on Health, is the highest policy-making body within the Nigerian health sector. And it happens usually once or twice a year, and is chaired by the Minister of Health, and in presence, in attendance will be all the commissioners of states from the 36 states plus FCT, and all their key directors, permanent secretaries will all participate in that. In addition to international, what we call development partners, public health, all the different organizations that are doing public health work, the media, traditional people. So it's like well listed. So in the National Health Act of 2014, it lists out what is the composition of the Nigerian health system and who can attend the National Council on Health. So it's important that we, as rehabilitation therapists, keep in mind and monitor what are the policy changes or developments happening within our country, because it's important for us to participate in the policy process. So I cannot overemphasize that. So we have a new health sector renewal initiative or blueprint, which Dr. Pate started, and I may not have to go through the policy process. So that it was first introduced to Nigerian health sector players November last year. So we had the National Council on Health in Ekiti in November, I think it was middle of November last year. So Dr. Pate presented his vision about kind of renewing or reforming the health sector. And then between that time and now, there has been a lot of engagement with state players, with professional bodies, with commissioners of health, and a whole lot of other people. And of course, development partners or donors. And I've attended some of those meetings. So in July, a draft of the National Health Blueprint or the new agenda was reviewed in Abuja, and we had several people come in. It's a big document, but I will now walk you through some of the key elements of that new health agenda so that we are kept informed. So can you guys see this slide? So the new health agenda, so this is the overview of the new health agenda. So the goal of this new health policy or reform is to save lives, reduce both physical and financial pain, and produce health for all Nigerians. So if you recall previously, we had what is DALI, disability adjusted life years, improvement, saving lives. OOP is out of pocket payment, or out of pocket payment. So the concept of out of pocket payment within the framework of universal health coverage, we are not supposed to pay money at the point of care. So somebody is coming to receive rehabilitation services, or somebody needs surgery or needs to see a specialist. The idea is that finance or lack of money should not be a hindrance to anyone accessing any type of service. So paying out of pocket is not seen as a positive indicator of a country that is making improvements in its health outcomes. So ordinarily or ideally, a country's out-of-pocket expenditure should not be up to 30% when we look at how much is being spent within the health sector. So for Nigeria, for instance, our out-of-pocket expenditure is over 70%. So over 70% of Nigerian citizens pay from their pocket to receive services, whereas ideally, we should have what we call financial risk protection mechanisms like insurance, or maybe getting waivers to receive services. So, I mean, I'm just mentioning that. So that's why it is there as one of the key outcomes and issues around equity. But let me just quickly run through this new health agenda has 4 pillars. So the first pillar speaks to effective governance. For those who have who know what we call the health system pillars, the WHO 6 building blocks or health system pillars, leadership and governance is number 1. So leadership and governance speaks to how a country is governing its health sector, providing the right policies and frameworks and all, ensuring that the services are provided in the right way. And also, one of the pillars is to ensure that we have an effective governance of the health sector. So you could see some of the points there: strengthen oversight and effective implementation of National Health Act. National Health Act was signed into law by President Goodluck in 2014. And it lists the key provisions there. If we had implemented them in Nigeria, our health sector would have improved. So recognizing that gap, Dr. Pate is pushing to see how we can improve or strengthen the implementation of the National Health Act, and then a whole lot of other things. But the one that is of importance to us, because we are looking at rehabilitation services management, the number 2 pillar, efficient, equitable, and quality health system. If you see, for instance, the first bullet speaks to drive health promotion in a multi-sectoral way, including intersectionality with education, environment, wash, and nutrition. But the key word there I wanted to point out is health promotion. Recall that a lot of work we do as rehabilitation experts speaks to promoting health and prolonging life. Then second one says strengthen prevention through primary health care and community health care. We also do a lot of our work falls within the scope of health prevention, or preventing the occurrence of diseases, or preventing the complications of disability, so that people can overcome functional challenges to be able to live and carry out activities of daily living without much reliance on other people or carers, and improve quality of care and service delivery across public, that's primary, secondary, and tertiary, and across all levels of the health system. So you could see that rehabilitation is subsumed under service delivery, because when we say services will include prevention, promotion, curative, and rehabilitative services. So I'm providing this so that we see that there is a policy framework where we should be or we should operate in. Then unlocking the value chain is a separate one, but it speaks to how Nigeria can improve its capacity to produce all the necessary things we need to provide services. So in terms of service readiness. So as it stands, I know that most of the equipment, both physiotherapists, occupational therapists, speech therapists, and audiologists use in the respective clinics. I think majority of the equipment, we import them, even the very basic things. So part of the policy thrust is to improve the capacity of Nigeria as a country to produce the basic things we need, both equipment, commodities, drugs, essential drugs, by our own pharmaceutical industries. So there is a new, it's not an agency, but it's called Presidential Locking, it's called PVAC, Presidential Initiative on Value Chain for Health, PVAC. So there is a national coordinator who is now within the Ministry of Health, who is leading this work. So they are, for instance, trying to sign MOUs or bring in investors who can start producing some of the things we need. For instance, recently they signed an MOU with a company that can be producing mosquito nets, what we call insecticide treated nets, ITN, in Nigeria as part of control for malaria. So there are several of producing vaccines or drugs. And then the other one has to do with health security. We've discussed about health security speaks to still the infectious diseases that are of public health importance to ensure that we are able to detect them, prevent, and when we have any outbreak, able to respond. If it's Lassa fever, if it's cholera, whatever it is, measles, and all. So this just gives you an idea of what are the 4 pillars. So we call them the pillars of the new health agenda. And then underneath is what we call the enabling factors. For instance, data and digitization. So for today's course, we have to look at data, protecting data. So currently, I know in most hospitals, not all hospitals use electronic medical records. So there is an initiative called Nigeria Digital Health Initiative, which the ministry has just launched. So they made a call for proposals for health companies that are able to build electronic medical records to submit a bid. So the deadline was about 2 weeks, about a week or 2 weeks ago. Yes, about 2 weeks ago was the deadline. So Nigeria is already doing this. So the plan is to, first of all, so all the primary healthcare centers across Nigeria, especially there is a category of primary healthcare centers they call the ward PAC, ward as in a political ward. So there is a policy of the government to ensure that at least in a political ward, there is a primary healthcare center that is refurbished and revitalized and made ready to provide essential health services, that's primary healthcare services. So the plan is now to build an electronic medical or electronic health record system that will connect all the primary healthcare centers and also that connect the primary healthcare centers to the federal government owned services, especially the tertiary hospitals, the teaching hospitals, and the federal medical centers. So it's an elaborate design, and the work is in progress, but we are hoping that this will work because that way we will transition from paper-based documentation of health records and then move to digital records. So that process is ongoing. And then I know that as part of today's course, there was also the idea about how do we protect data. So there are policies that are already existing. So, for instance, we have the Nigerian Cybersecurity Act, which Nigeria Information Technology Development Agency put in place to ensure that data is protected. Patient data should be there should be privacy and confidentiality, and making sure that nobody who doesn't have the right to access a particular patient data shouldn't. So there are mechanisms and laws for that. So we know that the National Health Act also has a provision that speaks to protecting the confidentiality of patients' record. So let's keep it in mind that the records when we clerk a patient, document, do our assessment, make our diagnosis and then plan our treatment, we should make sure that those records are protected. For instance, when I was in the National Health Ethics Committee, part of the requirement is that if you submit a protocol for research, you need to include a provision on how you are going to protect the data you are collecting, especially for human subject-based research. So there are specific requirements. For instance, if you collect data either from a questionnaire or you did what we call key informant interviews, like qualitative research, where you record the voice of a subject. The idea is to make sure that such data are stored, even though they are electronic digital data, they are stored in a file that is passworded, and so that a third party cannot have access to such. So because data privacy is an important thing these days. If you know, it's really, really important that we keep that in mind. And then financing components. So, this is an overview of what the new health agenda is. Now, as part of this new health agenda, okay, sorry, just don't mind, but there is what we call sector-wide approach. So the new policy is to be implemented in a sector-wide approach. So in terms of sector-wide approach, what it means is that you want to make sure that you have one plan. So rather than have 36 state plans, you just have one country plan. And then you have one funding mechanism. So you pool funding, or at least you mainstream or streamline the financial resources for implementing the plan. So not that every donor, for instance, as it is, we have different public health programs that don't speak to each other. So maybe USAID, that's the US government's international agency for development, can just come into Nigeria and say, okay, this is what we want to do. And they don't need to consult the government. They just go ahead because they have the money, and then they just implement. UK government will come and do its own. The foundations, Bill Gates Foundation, and several other funders who will come and they decide to do what they want to do in Nigeria. But if you are trying to improve health or to reduce what we call the poor, improve the health outcomes, to reduce maternal mortality and all, then you need to pool all the resources together and have one vision or one mission. So that way, we may be able to improve our health outcomes. So this is one of the key principles that Dr. Pate is making sure that this program, this new health agenda is not like the previous ones where everything goes. So it has, if you look to the right of the slide, it says it has 21 priority areas or priority initiatives. Then we have 13 health sector priorities. You may not so much about that because this plan will be launched or approved during the next National Council on Health. But I just wanted to bring it to your attention so that we are aware of the policy developments within our sector. So if you look, this next slide shows this next slide shows the key 13 health sector priorities that this current government want to tackle. So priority one is to improve reproductive, maternal, newborn, and child health, plus nutrition across the continuum of care or across the lifespan. So we know that Nigeria still has one of the worst numbers when it comes to infant mortality, child mortality, or even the disease. Then the second priority, which is also of interest, it has some relevance to the work we do as rehabilitation therapists, is to accelerate immunization programs for priority antigens. We know that polio remains one of the vaccine preventable diseases that we still see within our clinics and departments. So the plan is to make sure that every child in Nigeria is immunized, and across all these priority disease areas. Then the other one that is also of importance to us as rehabilitation experts is priority number 3. It says to slow down the growth rate of NCD prevalence. So we have talked about NCDs as part of the previous slides we had discussed. So we have stroke, we have hypertension, we have diabetes, and all the other non-communicable diseases. And one key public health of significance is that most non-communicable diseases, to reverse the trend, will require rehabilitation experts to sensitize the public against those, what we call the modifiable risk factors, such as smoking, sedentary life or physical inactivity, people, alcohol, or eating junks and all. So we should have it in our mind that we have a role to play in slowing down the growth of non-communicable diseases. And then I'll leave number 4. Number 5, improve the quality of care and delivery in PAC and secondary facilities. So rehabilitation services are subsumed under this service delivery. And another one of importance would be, for instance, number 7, increase the availability and quality of human resources for health. HRH means human resources for health. So rehabilitation professionals are part of the human resources for health we have. So to increase the availability, the number of rehabilitation experts that are supposed to work at primary healthcare, secondary healthcare, and tertiary level is an area of importance. And then, because we are discussing about data, I will also, number 9 too speaks to rehabilitation, because some of within the National Health Insurance, physiotherapy and other rehab services are considered more like specialized services as well, beyond the promotion side. So if somebody has stroke or has stroke, for instance, the rehabilitation is seen as a specialized care. And then the other one of importance, because today we are discussing data, is number 12, that speaks to strengthen health data collection, reporting, and usage, starting with the core indicators. So we don't have a rehabilitation health management information system because, like I said earlier, most countries are just starting or waking up to see how they can integrate rehab into their health system. So if we are to measure, for instance, how many people need rehabilitation services across the spectrum, whether it's physiotherapy, occupational therapy, prosthetics, audiology and speech, we don't have that data. So we should, as a country or as a rehabilitation community, we may need to start advocating for the government to pay more attention to rehab. But I'll just jump. So these are some of this is Dr. Pate. He has shared his vision in different ways, but I had mentioned about the increased coordination, making sure that all our public health or population health services or initiatives are well coordinated and stuff. So I'll leave out this. And so before I go to disability, if anybody has any question, I'll just pause here in case anybody has question or comments with respect to the new health agenda, because I feel it's important we have this background and contextual knowledge about what's going on in the health sector policy-wise before we zero in on rehab. Thank you. Feel free to ask questions or make comments in the chat box.
There is a hand raised up, so you can kindly unmute and ask your question.
Ochai, please go ahead.
Good afternoon, sir.
Good afternoon.
Yes, I have a question.
Please go ahead.
Yes, sir. We're talking about management and leadership, and you just mentioned some of the priorities, or let me say the agenda on health in Nigeria currently. Yeah. But my question is, whenever we have a new government, we now have new policies. And in fact, you even mentioned some of the things that are phased out in one or two governments that have passed. So what is the future of the health sector? Because all of us here are health practitioners, we're medically inclined. We need to know what is the future of our country in terms of health. These policies keep changing. People come with different visions and ideas. You start something and it doesn't last long, it ends there. People who benefit from it just lose hope. In fact, they lose confidence in governance and health practitioners, because it seems like it's not sustainable. So what would be your advice? What let me say assurance can you give us in the health sector that government can prioritize agenda or programs and make sure that it is sustainable, and then we'll see impact in the health sector? I don't know if you get what I'm trying to say, sir.
Okay, ma. I cannot speak for government. I'm not part of government.
I know, but, yeah, but like I'm impressed from what you're telling us. These are things that is happening recently in the government. How do we sustain these policies? How are we assured that these policies or these priorities that you have mentioned will be what the populace will experience and benefit from in terms of health promotion and education? That's just what I'm asking.
Yeah, no, I get you. Thank you so much. And yeah, so there's within the policy process, so you have certainly implementing a policy or having a government in continuum is the ideal thing. So for instance, just to give you an example, every policy, for it to be sustained, oftentimes might require a legislation. That's ideally in an environment like, so our environment, politically speaking, we are not matured as a democratic process. So in a democracy, a government is answerable to the people. So if a government says during campaign, I'm going to do X, Y, Z, and they are voted and going, if they don't do that, what they had promised, then the citizens have the right to hold them accountable. Accountable in the sense that not even to wait until the next election. So citizens are to ask questions. Many, many years ago, I worked with the Japanese donor agency, and each time my boss then will be saying, everything we are doing, we are accountable to the Japanese taxpayer. So the citizens, especially in developed countries, they have a say in what happens in government. If you recall, the UK Prime Minister was forced to resign because there was lockdown, he announced a policy of shutting down during the COVID, but he was partying with his guys. And these things, even though he lied initially, but at the end of the day, when everything blew up, he had to go. So I'm trying to say, I'm not justifying what is happening in Nigeria, but I'm trying to say, ideally, in places where policies are sustained, it also shows that they have a strong governance or a governance system. And that is why for health sector, the number one pillar in a health system is strong leadership and governance. So that is where coordinating the health sector is important. Let me give you an example. In Rwanda, Rwanda has, so health insurance, for instance, maybe many of us here work with government, so we have health insurance. But if we look at the pool of over 200 million Nigerians, you ask yourself, how many people are covered by health insurance through the government? Less than 20 million Nigerians out of 200 million have one form of health insurance or the other. Whereas in Rwanda, Rwanda has about 80 to 90% of the population are covered by health insurance. And the implication is that if someone in Rwanda falls sick or has stroke or needs rehabilitation services and they are poor, they don't need to worry because they have health insurance and they can go to a health facility to receive services without paying out of pocket. So, like I was saying earlier, over 70% of Nigerians pay for their own health services from their pocket. And you notice that almost all the patients we see every day in our clinics, they pay money, even if it's subsidized. I know that rehabilitation services are hugely subsidized compared to like how much people pay in the private sector. But for private sector or private clinics, almost everybody who receives services, they are paid out of pocket. So for health services, also health outcomes to improve, obviously, financing the health sector or providing the necessary financial resources, the human resources and all that, will require strong government action. So China, countries with strong leadership, their policies are implemented. Like in Japan, prime ministers change at will, but the will of government, as in the government systems are running like an autopilot. So policies, there is fidelity. When we say fidelity, staying true to policy happens. So I'm saying that is a problem that we have in our country. So is a collective problem because as citizens, we have to hold government. Sorry, somebody's mic is on. So anyway, let me just stop there because I'm trying to say the problem is leadership because people come in, they want to, their eyes is on the next election. So they want to do their own program and use it to push for the next election. So for instance, just give you an example, the Shopee program, when Goodluck removed partial removal of the subsidy on fuel. So the discussion then was like the savings from the subsidy will be used to target social services. So health, Dr. Pate designed the Shopee program for maternal and child health, where part of that money was used to upgrade some health facilities, employ midwives, and send them to remote areas where they don't have people to provide those services. But immediately Buhari came, he discontinued the program. So if a president said, I'm not going to continue with a program from my predecessor as an executive president, then there was nothing Nigerians could do. He canceled it. If you also recall, there was also a presidential scholarship for those who had first class and all. He canceled. So I'm trying to say that policy continuity is a key challenge and is the political class probably that would have to address that for now, maybe, and then with citizens putting pressure on them. So if for instance, let me give you an example. I'm sorry, I'm stretching. So in Ghana, Ghana has a very strong citizens engagement with respect to health. So if you are to win election as a president in Ghana, don't ever touch the Ghana National Health Insurance because it provides coverage for majority of the masses. So any effort to reduce how much government is providing for health insurance, that president or that election will go against the incumbent. It's almost similar to UK. So the UK National Health Service, NHS, is a key part of the political agenda. If you look at the current prime minister or the previous ones, if you hear them maybe before elections, they will speak so much about funding the NHS, as in increasing the funding for NHS. Because NHS has become a legacy of over 75 years, I think, that has been providing services. So if you live in UK, you fall sick, you walk into a clinic. They have what they call walk-in clinics. You can see a doctor, outpatient, they treat you, you go away. They also do nurses and all. Anyway, let me move ahead. I'm trying to say is part of our political system that is causing that. All right, so I'm also keeping an eye on the time. Here, because we want to kind of refresh our memory on policies. So we have the National Health Policy of 2016. It speaks to different things, but within that 2016 National Health Policy, there is a component that speaks to disability. So if you see, so the goal under that subsection, a policy thrust on disability, is to ensure attainment of well-being that would enable people living with disabilities achieve economically productive lives. And our work as rehabilitation therapists or specialists is to ensure that when people have injuries or disease, that they are able to return back to society and be independent and be productive. So the National Health Policy has a component on that. So the key objectives of the disability component of the national policy is to reduce the burden of disabilities in the country, to ensure easy access. Recall that for today's work, today's lecture or course, we also, issues of access is there. So that's why I intentionally brought this component of the health policy so that we see that there's actually a policy framework that speaks to that. Easy access to health services by persons living with disabilities. Then number 3, reduce the morbidity and mortality and sequelae associated with disabilities. And then to improve the quality of life for people living with disabilities. So this is here, and then the policy orientation and initiatives are also listed there. I may not have to go through all of them so that we can save some time. But I would also want to mention, I don't know if some of us have ever read the Anti-Disability Discrimination Act of 2018 that Buhari signed. I don't know. Okay, if you are aware of that Disability Act of 2018, maybe do a thumbs up. Let me see. Or you can type in the chat box. Yes, if you are aware, you know about the Disability Act. Please, let's use in the next 2 minutes to type yes or no in the chat box, just to have an idea. Yeah, one more people. I'm seeing a couple of no's and a few yes. Okay. Okay, so Fatima says, I have read through parts of the act. So Fatima, please, if you don't mind, since majority of people don't know about it, can you share with us what you know from your reading of the act? Hello, Fatima. Please unmute yourself.
Hello, sir.
Good, please go ahead.
Hello, sir. Good afternoon.
Good afternoon.
So, the Prohibition Against the Persons with Disability Discrimination Act was signed by President Buhari, I think, around 2019-20, and it captures all around. It captures all around in all aspects of persons with disability. It captures there are laws attached to it to prevent discrimination of persons with disabilities in schools, in healthcare, with employment, and all aspects of human life. So, and there are laws attached to it, for which a person with disability, when being discriminated, can report, or it can be reported. And there are the laws attached to it, and I would say people that violated laws, these laws can be punished under the constitution, using the constitution. So the act led to the establishment of the National
Commission.
I think
National Commission on Persons with Disabilities.
National Council or National
National Commission. National Commission on Persons with Disabilities. Yes, you are right. Did you hear me?
Commission, yes, the National Commission of Persons. Commission was placed in charge of looks into the inclusion of human endeavors. So it's not only in healthcare, but also in education, and their social protection in employment of them.
Thank you so much. You did so well. Thank you. So
their inclusion into the society in general is extensive, and there are many laws attached to it.
Thank you so much. Please, I don't know if there's a way we can clap for her. She did well. So you see the importance of monitoring the policy environment. So we have.
Ai na zaci sai an ɗan ja lokaci tun da zan kawai.
Sorry, please mute your microphone. Or can we mute the person? Okay. Yeah, so one takeaway for us is that it's important to keep track of the policy environment, the legislations, and the frameworks that have implications for the work we do. So maybe today, after the class, you could just type Disability Act, Nigerian Disability Act. It's all over the internet. You could just take your time to read that law and see where it has implications for the work. So issues of access, because we are to discuss access as part of our discussion today. So access to rehabilitation services, access to public buildings. So for instance, in our clinics and our facilities, are they disability friendly? Do they have, so can a person with disability easily walk into our facilities? Somebody who is wheelchair bound, is there a ramp for them to be wheeled into the department or the hospital? Do we have lifts for those who cannot climb? even if they have wheelchair, somebody with wheelchair cannot climb the stairs. So do we have lifts that can take them up, or do we have ramps? Do we have elevators or escalators that can? So issues of access to public buildings. So in a sense, it's part of our public health responsibility to advocate, to bring to light. So I remember one of our colleagues, Dr. Olumide Dada in University of Ibadan, there was a time he did, I think it was just like a short campaign for people to take pictures of their clinics or their departments to see how disability friendly or accessible they are. So it's really important that because we are the closest, we are the health professionals that engage with persons with disability, especially those with physical disabilities or even intellectual disabilities and all. We encounter them and they need a voice. And we are the only ones who understand their unique challenges, the unique barriers they face in society in terms of their functioning. And we can become advocates or influencers, people who speak on their behalf, because we understand their peculiar health needs. So that's just why I brought up that policy, because we talked about having improved access to health services for persons with disabilities and all. So yes, so we have a commission, National Commission on Persons with Disabilities, is based there in Abuja, and a lot of states. So we also, I mean, before I even go to the state, at the national level, we have a presidential advisor, that's senior special advisor to the president on disability matters. So we have that for the first time in government, having someone who is a special advisor. We have a special advisor on health. We also have on disabilities. And then the National Commission on Persons with Disabilities speaks for persons with disabilities and all. And just before I move on, last year, the MRTV organized a stakeholder workshop where we discussed about how to bring disability into the forefront of universal health coverage or discussions within here. So some progress has been made. I know that the minister set up a committee, a high-level committee that looks at issues of rehabilitation and disability, which the registrar is a member of that committee. And I'm also aware that the minister, through that committee, had started initiating some efforts or making some efforts. Like there's a committee that is to be formed, like a implementation committee that would advise the government. So as it stands now, we don't have a rehabilitation policy, rehabilitation services policy. So if we are able to develop a strategic plan for rehab, then so WHO, part of what it's encouraging countries is to have a strategic plan that focuses on how to mainstream and strengthen rehabilitation services. So the board is leading that charge with support from the professional bodies, and I'm hopeful that we might be able to make some progress. So a country like Uganda, I shared that with the MRTB registrar, I think last month. They have a strategic plan for rehabilitation. So there's a policy and strategic plan for rehabilitation we don't have in Nigeria. So hopefully during this government, before the government ends, maybe hopefully by next year, we probably will be able to get or have a strategic plan for rehabilitation in Nigeria, which would help advance the cost of rehabilitation in our country. So I want to move now.
So there's a question here for you.
Oh, okay, let me check. Okay. Please, can you read out the question?
John Obaka said, can someone with disability become a physiotherapist in Nigeria, like a blind person?
Yes, at least One of my mentors, when I was a student in Kano, Malam Halilu, he trained as I think, the first blind physiotherapist in Nigeria, if I'm not mistaken. He trained in England, and he's blind from birth. It's not as if he became blind after as an adult. He trained after he became a physiotherapist. He trained as a physiotherapist. He's a blind man, but trained as a physiotherapist. And he was the head of department of the physiotherapy department at National Orthopedic Hospital, Dala Kano, for so many years before he retired. And he was a very astounding physiotherapist, well respected. We also had another Gani Ikilama from Zaria, who was also a blind physiotherapist. Very excellent. When I mean excellent and competent, they were, as in those two stood out. They were, I mean, as a young physiotherapist. Yeah, so I'm trying to tell you, yes. Yes, so we have. Yes. Okay, great.
He said that that was
Sorry, can you please mute your mic? Thank you. So yes, so disability is not a hindrance to practicing at all. So he could examine patients, he could do a lot of assessments with his hands. So he practiced for years before he retired. So now, another topic we are supposed to discuss today is on human resource planning for rehabilitation services. So why, if you recall earlier, when we were asking in terms of service availability and readiness, having the right type of staff or experts to provide that service is critical for planning rehabilitation services. So I looked at so we have what we call the National Policy on Human Resources for Health in Nigeria. It's a bit old, maybe needs revision, but so the figures you are seeing in your front gives you an idea of what the human resource picture is. So I think we all know that WHO has some ideal numbers in terms of ratio of health worker to the population. So for developed countries, they constantly monitor the ratio of the health workers across the specialist areas or different professions versus the population. So as the population is growing or as the demography is changing, demography we mean is when you classify people young or in terms of sex or age. So in developed countries, their own epidemiological transition is that more people, because their health services are optimal, improved, so life expectancy is high. For a country like Japan, they have so many old people. I was in Nagasaki sometime in May, and so we visited the mayor of Nagasaki, and he told us that their population had dwindled over the last couple of decades. So they are trying what they can to attract young people to come to their city, their state in a sense. So because they have more older people who are not able to work, they are retired and stuff. So different countries are having, so the kind of burden they would be dealing with in places like Japan, where longevity is high, would be they need high burden of geriatric services. They need to provide NCDs and all. Whereas a country like us, our life expectancy is not as high. I think about 42 or maybe close to 50 for females. So the demography is different. So the number of health workers we need is huge because we have a huge population. Those other countries, the fertility rate is dropping. So maybe a woman, a couple, not everybody is getting married, or even those who are married, they may have 1 or 2 kids. So their fertility rate is dropping and they don't have enough what we call replacement rate. So what some countries, especially in the West we mean geopolitically, includes North America and Europe, and some parts of Asia like Japan, they are encouraging skilled migration. So that's why JAPA is favoring countries like UK, Canada, because they want to ensure that they have the close to optimal number of health workers to attend to their population. But in our country, we are not doing that. So if you look at this table, this is as old as 2022, notwithstanding, but you will bear with me, or you would, agree with me that these figures would have been worse compared to what this year is, because the jackpot that has happened among health professionals, the brain drain is becoming a worry because those who are staying, they may go tomorrow. So see medical doctors, 65,000, and then population ratio per 100,000. That's the metrics that is used, 38.9%. This is 2012. Now see nurses, about almost 250,000 nurses, but we know the number of jackpot nurses that left. So these figures, just to give you an idea, so only nurses, their rate is a little bit higher compared to all others. But of interest would be, so we see radiographers, 1,000. Okay, let's check pharmacists, 16,000. And population ratio per 100,000 is 10. But let's go down to radiographers. Radiographers, 1,286. The ratio is 0.76. Now, medical lab scientists, 19,000, 11.3. So among all the health professionals, you could see that it's only doctors, it's only nurses that has this higher rate. Doctors, maybe because they are more in number, 38.9. But if you look down, physiotherapists, we just have 2,808 as at that 2012. This is what the ratio is. So now why I brought out this table is to see the implication it has for service availability and readiness assessment we discussed earlier. So it's obvious that the burden, so we have, I think, about 25 million persons with disabilities in Nigeria. That's on one side. And then what we call the rehabilitation needs, the needs for rehabilitation. That's people who need rehabilitation. They are not necessarily persons with disabilities. Somebody with back pain, people who have, who require physiotherapy, occupational therapy, or other forms of rehabilitation therapies. So if our numbers are this small relative to a population of over 200 million, so that tells us that there is a huge burden or a huge need for rehabilitation services. So in a sense, what we call gap, service availability or readiness gap. So the gap is so huge, we don't have enough professionals to provide these services. That's on one side. Then in terms of facilities, we don't have enough. So when we are looking at health infrastructure, so we also look at what we call geographic access. So geographic access is an indicator we use to monitor the availability of health services. So in a given population, how many facilities can people go to receive physiotherapy, occupational therapy, or if they need prosthetics and all? Do we have enough? So in Lagos, I'm in Lagos today. So how many, if somebody in Surulere needs rehabilitation services, how many kilometers away would they need to travel to access such service? And when they get to those facilities, do they have enough professionals who are competent and trained to provide those services? So these are the realities that we need to take into consideration while planning for or managing rehabilitation services. So I just wanted to bring this to our notice, and I think it aligns with the realities we face in our different health institutions. Do we have any questions, or should I pause a bit here?
You can go on, sir.
Okay, great. So I just want to highlight, still talking about the human resources for health with respect to rehabilitation. So I want to walk us through. So we have a national human resources policy, but within the 2016 National Health Policy, we have a section on human resources for health. So within the policy, we usually look, the policy covers all the what we call the 6 pillars of the health system. So look at leadership and governance, look at service delivery. So the disability and rehab services we looked earlier falls under service delivery. Then we have the human resources for health. So if we are to plan for rehabilitation services, we will need to look at it within the framework of this policy. So we need to, in terms of human resource, so there is what we call, as in the critical elements for addressing human resources speaks to one, do we have an institutional framework for human resource planning? So where we plan how we want to produce. So in some countries, as they look at the epidemiological picture or transition, they make adjustments. So if you notice that UK started asking caregivers, giving them opportunity to come to UK. And then when they reach some level of saturation, they close that gap. So they stop issuing maybe visas. Canada was also allowing caregivers because they are countries that need such services. So they have a huge geriatric population who need home care and all. So they open that. So that's part of human resource planning. So they project what the needs are, and then it's okay, which categories do we need to fill this gap, to provide this service that we need where we have gaps. So they identify, and then they initiate a policy response. So they say, okay, let's kind of let's reduce the visa requirements for people like this within a time frame, because a policy is to be implemented within a time frame. And if they monitor and see that the numbers are okay, is green, maybe not red or amber, they now maybe shut down that policy. So then you look at production. So production under human resources, we are looking at how many people are we producing every year. So across the different rehabilitation disciplines and professions, are we producing enough? Now, production is one thing. So more like how many medical schools, how many students are we admitting? If you notice, for instance, schools of nursing, they usually will have a cap, maybe 50 for each cohort they are admitting. So it's part of the planning process, because they want to make sure they are producing, they have the right number of instructors who will train these people to the point of competency. So some medical schools, you've noticed that some medical schools have had to lose their accreditation because either they are over admitting medical students and they don't have enough teachers and clinicians to train them. So these are all parts. So if we are to, we also to keep this type of framework in mind when we are discussing or planning for rehabilitation. So recruitment is another. So when we plan, we produce the professionals. Are we employing enough? In some places, some governments, because here we are not doing proper human resource planning, you realize that they have some embargo on employment, yet people are retiring, people are jackbarring and leaving, but they are not being replaced like countries like where people are jackbarring to England, Australia, Canada, Saudi Arabia, Kuwait, and all of those places. So because those guys are planning, they are keeping an eye on the needs of their society. And if, I remember, I think it was either a year or 2 years ago, we had some delegation from Saudi Arabia that came to Nigeria to interview consultants and recruit them right away. So these are, because those countries they have a framework for planning and recruiting human resource that they need for their health sector. So distribution speaks to geography. So if we have health professionals, rehabilitation professionals, are we properly distributed? Is it skewed towards a particular geographic area or not? So for equity, to ensure that people who need rehabilitation services get access. So that means as a country, we need to be deliberate about how we employ, how we distribute human resources, and then, of course, managing the human resources. And in terms of practices, do we have the right guidelines, standard operating protocols or procedures? Are we updating our clinical protocols regularly to ensure that our services we are providing are evidence-based clinical services or medical services or rehab services we are providing? So these all fall under human resource for health planning. So you could see that the objectives, I'm just running through it to see how it applies to rehabilitation. So I may have to, so this human resources policy, we also have some other ones I didn't list here. I don't know if we have heard about the tax shifting policy. Anyone here who has heard about the tax shifting policy? If you have, you can drop a comment, say yes or no. Or maybe those who know about the policy, you can type yes. I believe majority will be no. Just want to ask if anybody knows. Otherwise, I can explain what it is about. Okay, so let me quickly explain. So this is a sub-sectoral policy. When we say sub-sectoral, so we have health, human resources for health is one. Now under human, so a few years ago, it's up to like 10 years. So I was involved in this process. So the background is that because women are dying in their numbers, and one major cause of death during delivery is what we call postpartum hemorrhage, PPH, postpartum hemorrhage. So we know what is hemorrhage. So bleeding during delivery when the woman is in labor. So it's a very critical thing. And if we don't address, so there are some drugs that are used to address or to control the bleeding. So we have some of them. Now, in regular medical practice, it's mainly doctors that administer that, or trained, maybe midwives that could, maybe oxytocin and some of those ones that are given. So, but it was observed that majority of primary healthcare centers where these women go to deliver. So we are encouraging, so within WHO framework, a country is called based on the number of women that deliver in a facility. That's a health facility that has the right equipment, because we know that facility-based deliveries, the outcomes are much better. Because if there's an emergency, you have the right people who have the skills and the knowledge and competencies to provide that emergency care. If it's CS that is required, you have an obstetrician who can quickly cut open and bring out the baby. So it's critical for when we have prolonged obstructed labor and all of that. So because we don't have enough midwives, and we really don't, you know, in Nigeria, doctors don't work in primary health centers, maybe except for Lagos, where we have some doctors who work either at the local government level or even at primary care level, primary health center. So Nigeria, so there were some pilot that was some pilots conducted in the north to see if, for instance, in the previous slide, you see, let me go back just to show you something. Yeah, you could see that we have community health workers, community health officers, CHOs. We have the community health extension workers, that's CHUs, and then you have the junior CHU. So these categories of workers, they work mainly in primary healthcare centers. So the government decided to say, okay, can we train them to be able to administer these postpartum hemorrhage drugs to reduce? And they piloted it. So for most public health programs, you usually run a pilot just to test. It's like a clinical trial if it is what we do in clinical medicine. So randomized controlled trial, RCT, you run that. If it works, then you can scale. So something like that was done. I realized that if these people are trained, if they're able to identify the risk factors or signs and symptoms that point to danger, then they can do this. So after that was done, Nigeria said, okay, we now need to have a policy that kind of a policy framework under which this can be done. So that was where the national tax shifting and task sharing policy was done. It was not easy because a lot of nurses and midwives pushed against it, but eventually there was some consensus that was reached. Okay, they can do that under supervision. But so as it stands today, especially in North or places where you don't have a midwife or a nurse, some community health extension workers actually do provide delivery services or even antenatal. So that's what health human resource planning can do. Now, I need to be honest with you guys that for rehabilitation, if we are to meet the rehab needs of Nigerian citizens, there may be a need to revisit or review what level of services can be provided at which level. So we've not done that for rehab. And I'm hoping that the rehab strategic plan will provide a framework for doing that. Otherwise, as the more persons with disability, they are getting more empowered and they also want to receive the optimum services. Are we ready as a professional group of therapists to be able to provide that? So it requires policy, having a policy framework that can be implemented and also funded to do all of that. So I just use that as an example of human resource planning. We don't have one for physio at the moment, but I'll show you something else. So we have discussed the Discrimination Against Persons with Disability Prohibition Act. So I don't want to go to it again because our colleague really walked through it, but you could see that it prohibits every or any form of discrimination against persons with disabilities, and it calls for equal rights of access to physical environment, equal rights to education, adequate healthcare, where we fit in, as well as economic opportunities. Great. So this will be our last here before we take a quick pause or to ask questions. So can someone read the headline or the title of this slide? Just unmute your microphone. Just read. I want to hear someone's voice. It's quiet in the room. Maybe I'll call someone. Anu Feisike Abegunrin, can you unmute yourself and help me read, please? Looks like no one is Volunteering is okay. So WHO, as part of the Rehabilitation 2030 agenda, in I think 2023, developed what we call the Guide for Rehabilitation Workforce Evaluation. So if we are to plan for rehabilitation workforce,
sorry, sir. They said they could not unmute because the host has muted everybody.
Oh, okay. All right. Okay, host, I beg, unmute somebody. I want someone to read this so that we can discuss. Okay, Francis or Didika, please. Host, please unmute Francis. Yeah, Francis.
Good afternoon, everyone.
Good afternoon. Go ahead.
The Guide for Rehabilitation Workforce Evaluation.
Yeah, continue.
Go away.
If I can.
Yes, go ahead. Can we hear him?
The slide is very tiny.
Seriously?
Okay, I think I will help to read it. It's not too tiny for me.
Okay, please go ahead.
The Guide for Rehabilitation Workforce Evaluation. The Guide for Rehabilitation Workforce Evaluation is a set of resources that can be used to support the workforce planning and development in countries. GROW-E applies a labor market and competency analysis approach to help stakeholders not only capture the state of the rehabilitation workforce, but to understand problems and opportunities. Should I continue?
Yes, please.
All right, sir.
The second bullet.
Implementation of GROW-E involves 4 phases. 1, evaluation. 2, data validation. 3, conclusions and recommendations. And 4, planning and implementation. These 4 phases encompass 10 steps as outlined below.
That's
Step
fine.
1.
No,
okay,
just stop. Yes.
All right, sir.
Great. So why I'm bringing this is to see that there is a framework for us to plan rehabilitation services, specifically looking at the rehabilitation health workforce. It's really important. So as a country or as a state, if we want to plan for rehabilitation, we already have a framework that is here. So just recently, I think Georgia is one of the countries in Eastern Europe. They just held a workshop to validate their own GROW-E assessment. So they conducted the assessment. Ukraine, so my organization, we've been working closely. So we did some work in Georgia to support rehabilitation. So doing the assessment, helping to develop their implementation plan and stuff. So we haven't done that in Nigeria, but it's important for us as rehabilitation specialists to know that we don't need to reinvent the wheel, like we will say. So there's already a process that has been tested and implemented and all. So there is a book. So I'm going to share, when we are sharing the slides, I'll include the links to a couple of the resource materials that all of us as professionals can read, including the Disability Act and relevant resources that will help us. So I use the public health approach, looking at us planning from a population level. So because in public health, we are not looking at one individual. So we are not looking at an individual's health, but the population, the community. So if we are to do something at scale, then we need to walk through some of these steps. So if we really need to, so first of all, so just to step back a bit, for any population level intervention or public health intervention, before you do any intervention, whether it is to control malaria or prevent malaria, whether it is cancer, whatever it is, NCDs, you usually will need to do what we call situation assessment. You want to, is a first thing to collect data. It's okay, what are the issues? You want to understand, just like if someone wants to invest in an innovation, like we have these fintechs and all, before an investor will invest money, they will usually conduct market survey or market analysis. So they know what is the situation on ground, then it will help them to know how best, what strategy they can implement to achieve their results. So for rehabilitation, growing involves 4 key phases. The evaluation. So the evaluation is the steps, the processes for collecting the data to make sense what the situation is, or situation analysis. Then when you collect the data, you do the analysis. After you do the analysis, then there's what we call the validation. So just last week, my organization, for instance, the Bill Gates Foundation has asked us to do an assessment on maternal and child health commodities in Nigeria. So, and the essence is to know, there's a specific one. So because to improve maternal mortality, to reduce maternal mortality, there are some critical commodities that women who are, sorry about that. So we did that assessment. We went to some states to collect data from their ministries of health. They also have what we call the drug management agency and different in terms of supply chain. So we collected all that data and then did some analysis, analyzed the data. But before we can publish the data or send to the funder, Gates Foundation, that asked us to do that assessment, we had to bring the folks from those states to Abuja to do the data validation. So if, for instance, we conducted interviews and we transcribed and did all the analysis and then maybe got some quotes, we want to make sure that there is fidelity or validation of that is exactly what they said or what they meant. And if you collected data that says, oh, we have 100 maybe physiotherapists in Kano, for instance, and maybe we got it from the NSP, that's Nigerian Society of Physiotherapy Kano chapter, we may need to invite the president or the chapter president or chairman to say, this data we collected, does it truly represent what is on ground in your state? Did we get the numbers right? So that's all what the validation is all about. So in public health, when we collect data, either through monitoring and evaluation, or we are doing an assessment, after you have collected data, cleaned, done your analysis, it's important to validate before you can draw conclusions or publish that or use that data for policy decisions. So then the conclusions and recommendation, then after you have concluded, based on that, so in your conclusion, you would have made some policy recommendations. So, okay, do X, Y, Z. And then you outline that. Then you now have an implementation plan. So for instance, so Dr. Pate has already shared what his vision for health sector is, and then there's a policy, but there is an implementation plan. So as part of the implementation plan, you need to fund the plan. So there is something we call work plan. So in public health programs, so for you to implement, whether it's a campaign or any type of intervention, you would normally develop a work plan. Apologies that I didn't bring like a template or a sample. So a work plan, you have your objectives you want to achieve. Then you think of, okay, what are the key steps or actions or things I need to do to achieve that goal? So there will be activities. So you have a goal or objective you want to achieve. Then you have all the steps laid out, steps that are very clear. So you may have, okay, for instance, maybe one of the steps will be to develop a rehabilitation. So if we do the assessment, for instance, use GrowAway. So I had moved back. Sorry, yeah. So let me just walk through some of the tests, then I can explain. So the first step within this 4 phase. So for phase 1, which is the evaluation, so you collect workforce coverage assessment. So in this workforce coverage, so if we are looking at rehabilitation, so within the within the catchment area, so let's say Lagos, we may want to know how many physiotherapists are working or based in Lagos. So we need to collect that data. So from all the hospitals, how many occupational therapists do we have in Lagos, for example? How many speech therapists do we have who are working in Lagos? How many prosthetics and orthotics? How many osteopaths or chiropractors? That sort of thing. So we get the data. Sorry, I need to charge my phone and my laptop. Okay. So that's what the workforce coverage assessment is about. So when we collect, map how many people, who are they, the different categories, the years of experience in terms of demographic data, how many women or men, like, so we get all of that data. So that's what the assessment. So what qualifications do they have? Is it many of them undergraduate? They have BSc. How many have master's degree? How many have PhDs, or who have done any specialist program? So that comprehensive data would be about what the assessment would be. So then the political economy analysis. So political economy is an interesting analysis. So I've been involved in doing that once. So the idea of political economy, I think, is very critical. For that question, someone had asked, why do our policies why are they not sustained? So the key reality is the political economic dynamic. So in political economy, within public sector or public policy, what it looks like is, just in simple terms, is who are the power brokers within that sector. You look at what type of policies are there, who have interest to protect. So the power play and the interest within that. So if you look at the health sector, for instance, so a political economy analysis or a political economy dimensions of the health sector, if we look at interprofessional rivalry, to understand that, to unpack it, you will need to do a political economy analysis. So what are the interests of the different professional groups? If you notice, so if you use a political economy lens to look at the health sector, you will see why things are the way they are. So political economy analysis looks at interplay of power, interplay of interest, who has the influence to do what and all, and how are they advancing their own agenda. So if we don't understand the political economy dimensions of rehabilitation in Nigeria, if we are to make any advance in terms of planning, then, because when you understand the political economy dynamics, then you are able to maybe push for policy change, or even unlock maybe barriers to implementing a policy. Let me give you an example. So if we look, for the Shopee program, I was involved in a study. So we used what they call realist approach, is a qualitative research approach. So we try to find out, so for instance, why did Buhari not want to continue Shopee? To answer that, one will need to understand, what are the political forces at play? What are the economic dimensions? So in a policy, when you are formulating a policy, there will be those that will lose, who will be losers, and those who will gain from a policy. So if somebody is going to take, for instance, just to give you a practical example, with the fuel subsidy challenges we are having in Nigeria of fuel. So you realize that there are people who are interested in bringing in fuel importing from outside the country to Nigeria, irrespective of the economic implications for Nigeria, because that policy of getting access to foreign currency and then being able to import is an incentive for them. So if you go cut where they chop from, I will do everything to frustrate. So we now have Dangote refinery here in Lagos that is producing fuel, but initially the plan was that they will get crude oil from Port Harcourt, but that wasn't happening. And then he had to import from abroad. And then a refinery that we hoped that would help address the fuel scarcity challenges in Nigeria and also cut down flight of or deplete our foreign reserves. That you see all the shenanigans, all the fight between NNPC and Dangote refinery, and also with independent importers or petroleum products importers. So understanding all of this, we see it from the perspective of political economy. So economic interests to be protected and all. Was it not just last week or early this week, we saw in the news that, that Dangote refinery took NNPC to court. And then all of a sudden we just heard, that there was no court case and all. So to understand, I'm just using this word to see that it's important for us to understand what are the political forces at play that are impacting the rehabilitation services. So there is a framework for conducting political economy analysis. And I can share some examples for it. So one of my friends, he did a research, his PhD was on the policy process, how the National Health Insurance was established. And he used a political economy analytical framework for that. And what he found out from his study is that the private sector, the health maintenance organizations unduly influenced the establishment of National Health Insurance Scheme. So they made sure that the health insurance scheme is structured to favor and protect their interests. Because at that time, imagine early 2000, like when Obasanjo came in, Obasanjo set up the health insurance. By then, the Ministry of Health or people within the Ministry of Health have not any experience in anything insurance or health finance and health economics. There were no experts, but now we have health economists at the ministry and others. But at those early days, it was only the health maintenance organizations that were doing the America style of health insurance, managed care. So we have all those big HMOs. So because they already had power and influence, so they made sure that the operational guideline for implementing the National Health Insurance favored them. So they made sure, especially the monetary side, so they received money on behalf of NHIS and they had to pay health facilities for providing care. But for those of us who are involved in insurance, for instance, rehabilitation services, the amount allocated for rehabilitation is too small. So most physiotherapists or occupational therapists, you really don't get referrals from health insurance. Or even if you get referrals, the capitation or the fee for service rather is too small. So, but it was because HMOs made sure that their own interests were covered. So HMOs don't provide the service, for instance. They don't necessarily provide the service by themselves. So they recruit or enroll health providers, hospitals, clinics, for people to go and receive service, and they pay, but they get that money so they retain a huge amount of money. So it's through political economy analysis that you will understand how things are, what are the political undercurrents that is shaping a policy or reality, So sorry, I'm taking some time to explain what political economy analysis is. Then we have already discussed. So labor market analysis is also, so there's what, just like when you are doing market survey, so you're also looking at all the market forces that are determining who, for instance, if rehabilitation experts or professionals are paid very well, like medical doctors, there's a chance that more people would want to enroll to study any of the courses under rehabilitation. So the salary structure does not favor rehabilitation therapists, whether someone who is working in a public hospital or someone who is working in a private hospital. You could see that the salary is not very competitive compared to our medical doctor colleagues. So in a sense, or if we do we have as much financial resources to advocate and push for what we want? If you notice, pharmacists, because they are in business, majority are in business, so they own pharmacy outlets, some of them are into manufacturing. So as a profession, the pharmacists have more, they have stronger political and economic power to push for their own interests compared relative to rehabilitation therapies. So for instance, we know that the consultancy position, pharmacists got the approval. So what process did they take to get that done? Obviously, money would have exchanged hands, or they spent money to do lobby to get that approved. But rehabilitation therapists, in terms of number, I showed that data earlier. So in terms of number, we don't have that economy of scale. So even if we are to contribute, we are not involved in business compared to pharmacists or medical lab scientists. So you see that medical lab scientists, pharmacists are able to push for, so like for instance, medical lab scientists, they have been able to face the pathologists who want to take over their jobs in hospitals because they have the number and they have the money. They run private labs, so they make money. So they have more financial resources to be able to push and advocate for their own agenda or interests. So I'm just using that as an example so that both to explain labor market analysis as well as political economy analysis. Then the other thing is the workforce competency analysis. I think not too long ago, the WHO through the 2030 Rehabilitation 2030 released what we call the Rehabilitation Competency Framework, which specify what type of skills, in terms of technical skill, in terms of soft skills or behavioral competencies or behavioral aspects of competency that is required for rehabilitation services to be provided optimally. So it's important for us, all of us who are professionals, to also consult the Rehabilitation 2030 competency framework to understand that, because it specifies what type of education that is needed for a rehabilitation expert, what type of technical skills for you to be able to do assessment and treat and provide rehabilitation care for any patient or client. So that's also what we need to do if we are to do rehabilitation planning. And then in terms of projection is, if you, like Nigeria now, we say we are 200 million. So if we are to provide rehabilitation services to cover, like say 10, 20% of the Nigerian population, we will now need to have some data to make some modeling or projections to say, okay, if we are to close the gap in 2 years, do we need to expand our training programs? If we are to employ, so those projections like we discussed earlier. So that's what this projection. Then, so when we now building consensus is everybody aligning around an agenda or agreement and say, okay, we want to do this going forward. And that validation, we were saying data validation. So here I interpret the findings and draw conclusions, and then you clearly define the recommendations on what to do, and then have the report ready, and then have an implementation plan, which needs to be now funded, needs to be funded and rolled out. So I think I'll pause here for a bit to see the questions so that we can discuss. Any questions about the CROE or contributions? Please feel free. You can raise your hand or type your question in the box. Hello, I'm not hearing any voice. Please feel free. I want us to have the next 5 minutes to discuss, ask questions. Are there things you need more clarity? We can all discuss. If you have questions about rehabilitation with respect to planning, the workforce planning and all. Okay. So I'll take the silence as maybe I'm confused. It's either everybody has understood or have succeeded in confusing us. Okay. So in moving forward, so when we now have a plan, then you think of how do we fund it? How do we finance rehabilitation services? So we'll spend the next couple of minutes just to walk through financing from the perspective of rehabilitation at the end. So health financing pretty much speaks to what, when we say health financing or to finance rehabilitation services, we are looking at, okay, how do we pay for the services we are to provide? So if we have the right workforce, we have the right treatment protocols, people have been trained and all. The issue now is, the cocoa is, how do we pay? How do we resource and implement what our plan is? So that speaks to what health financing is about. So it's about how do we pay for goods and services with the aim of promoting health or preventing disabilities and all. So those are of importance to us as rehabilitation therapists. So we do say that health financing is one of the key pillars of the health system. So it's like a pivot. It can unlock, if it can make a lot of changes. So if we have the enough and adequate resources, we will be able to hire the right number of staff. So people who are going to abroad or JAPA, a critical factor is the salary. That's resources, because people are paid better out there than here in Nigeria. So financing is important for any health policy reform to achieve its desired objectives. So without the funding or lack of funding or dearth of funding, inadequate funding, then that makes policies like derail without being implemented to the letter. So I will move forward to, so within health systems or health finances, so there's what we call the health financing functions. It's not too technical, but you will realize when I walk through it. So we have what we call the 3 financing functions. The first function is revenue mobilization. We can also call it resource mobilization or generating funds. So you want to ask yourself is, if I am to fund rehabilitation services, where will I raise that money from? So that's the function of domestic resources or domestic resource mobilization. So for universal health coverage, WHO in 2010 released a report on health financing for achieving universal health coverage. And one key element is that countries that are able to achieve universal health coverage are those who are able to use their own resources, financial resources, to implement their programs without having to depend on donors or external funders. And if you look at Nigeria as a country, majority of the public health programs we have been implementing are funded by donors. The funds come from donors, whether it is HIV/AIDS, malaria, TB, even the maternal and child health, you just name it. Majority of our programs are funded by donors. And in health financing, we talk about sustainability of a program. So for a program to be sustained, it has to, the resources have to be from the owners of that program, not an external person. Take, for instance, so I came to Lagos yesterday for an event. There is an organization called the Private Sector Health Alliance, and there's a project they have been implementing. It's called Adopt a PHC. So the idea is that for PHCs that are not really functioning optimally, so they have this public-private partnership where some private sector players, okay, I will adopt a PHC, and over 5 years, I will provide the resources, financial resources needed to run that program, to cover the operational cost. So to run a facility, you need a budget for you to, the routine, buy the needed things, commodities, consumables for running that PHC center. So you have some banks like Access Bank, that's Wigwe. Wigwe, before he died, had adopted some primary health centers in Rivers State. So with his own money, through his foundation, they renovate these facilities and then also provide for maybe payment if they need ad hoc staff. And so provided them all, they renovated, and then, so the cost is 100 million to maintain a primary health center for 5 years. 100 million. So that means 20 million for each year to run a primary healthcare center to provide optimal services at that level. So that's the importance of. Now, at the meeting yesterday, the discussion is like, since the MOU with this private sector is only for 5 years, they'll pull out. So when they pull out, how will the resources needed to sustain the management of those PACs be filled, the gap in a sense? So that is a question that is important if one is planning for rehabilitation program. So the other function is what we call pooling and management of funds. So when you get this money, what mechanism do you have for ensuring that these monies are used efficiently? So that's what pooling is. So in health insurance, coming back to health insurance, so we speak about having one pool. So currently in Nigeria, we are running a very fragmented health financing mechanism. So NHIA only takes care mainly public civil servants. Then we have state health insurance schemes in all the 36 states. and also FCT. So we have 37 health insurance schemes in Nigeria, plus the federal one. So now in health financing, in terms of efficiency, when you pool, if it was only one health insurance pool that everybody belongs to, then operation or running costs will be low. There may be some level of efficiency and savings. But as it is now, so all the states just manage their own small pool. Lagos has its own, Oyo has, and all around. So we may not be able to achieve economies of scale because we have this fragmented and disparate pools. So for financing to be efficient, there's a need for reducing fragmentation and increasing the size. And then lastly, so when you now have this money together, the next is how do you pay for those services, what we call purchasing. So in terms of purchasing, there's what we call passive purchasing, is where you're not looking at the results. You just allocate money. So for instance, in budget, you just budget for services and just release the money. And for you, that's where it ends. But there's what we call strategic purchasing. Strategic purchasing, you are trying to use the money to achieve specific results. So the results are clear. So for instance, maybe we say for rehabilitation, we want to make sure that we provide rehabilitation services to, say, 10,000 stroke patients in a year. So how much would that cost? So do you have a specific result you want to achieve, or you want to attend to specific number of people with low back pain? What resources do you need to provide such care? If, for instance, you have children, maybe children with either birth injuries, so what do we need to provide that? We need to get splint or assistive devices. How many assistive devices do we need? How much will it cost? And all of that. So those specifics are important. So, so this is what we call purchasing of services. So purchasing rehabilitation services. You're looking at how do you allocate funds to obtain these rehabilitation services we need. Yeah, so I've already mentioned head financing, collecting and pooling funds. Okay. Great. So if we are to pay for rehabilitation services, otherwise we use the word purchasing because it's derived from economics. So health financing is a subset of economics. So there are three key decisions or questions. Sorry about that. So there are three key questions or decisions that we need to make. So how to buy the service or how to pay for rehabilitation services. So currently, can we just speak, how are we paying for rehabilitation services currently in the country? Can someone please unmute and tell us how people are paying for rehabilitation services? Please, anybody can, physiotherapists, occupational therapists, speech therapists, how are people paying for services in your facility or your domain?
So some people pay out of pocket, while some people pay via HMOs or insurance companies.
Okay. All right. So maybe if I twist it a bit, how do we, is there a mechanism or a formula that we use to determine how much patients pay for each service? Maybe.
Well, in physiotherapy, after you have pay for assessment, they pay for consultation. And after after they have paid for
sorry, just a minute. So for the consultation assessment, how do we determine how much the patient is paying? That's one of the things I wanted to ask.
Well, by His grace, I'm one of at Directorate in Keda. We have a decision on that. They pay uniformly for assessment, though it's still ridiculous compared to what our colleagues bill on private practice. I want to make us to know that government service is hyper subsidized, because the same patient that complained in the teaching hospital go to private service and they pay heavily. But it's generalized. Like in our place, the consultation fee is the same for all conditions. But when it comes to
how much, sorry, sir, how much is the consultation fee? Just for indicative, I just wanted to know.
Don't laugh at me. The management.
No, that's why it's important. It's important why I'm bringing this, so that if we are reviewing and planning for rehabilitation, then these are, when we are doing the market assessment, these are important. Yes.
Well, I will not mention the name of my institution so that I will not be.
No need. Please.
Management. So it's not I'm afraid, but as a manager, there are some things that can implicate. Well, we collect 1,500 for consultation at my hospital, and the patient pay another 2,000 naira for EPP. That EPP, many times we find some things we use in the clinic, we couldn't find it in the store. So like the sanitizer, the glove, the whatever, and so that it will not be unreceived. So patient pay for it, we collect the receipt. It is the receipt that we have per month that will determine what they will give us at the store. Yes. So and that is about 2,000 naira for every new patient. But consultation fee is 1,500. And on the condition, we classified physiotherapy patients into various categories. We have adult major, adult minor, and we have multiple presentation. Adult minor, somebody to be adult minor is the number of joints that is involved. If somebody is just having ankle sprain or having knee pain in secondary to osteoarthritis, that's adult minor. But if that minor will be using short wave, it's no longer minor, it's major. So the number of body parts you are going to treat and the modalities you are going to use determine the price. So if it is 2 joints, that is bilateral knee, it's adult major. If the patient is saying I'm still having back pain, join it, that is no longer major, it's multiple presentation. So you cannot cheat our equipment too. So and it varies for the adult minor, and we have reviewed it from 5,000 because management too need money now to something like 7,500. For the adult major, is around 12 or 15,000, and that's for 5 visits, please. We bill for 5 sessions, and multiple presentation. Is it 15? Is it around 10,500 or there or 15? But there is another category of patients. We call them will I say, is it multiple? No, it's not multiple, but they are not VIP. They are patients that will not want to come between. They cannot afford to come 8 a.m. and be sitting down. And by the time they come, they are big men in their own site. They want to be treated immediately because they are related to PS or one that is a daughter of a minister coming. So we have class for them. Those people pay 30,000 naira for 5 sessions. They must come. When they are coming, they call us. We say they should come. They must not wait at all. They must not wait. There is provision for people that sees them. And the only challenge sometimes, though we've not been able to overcome that, I'm a neuro. We believe that stroke rehabilitation is more demanding than ortho. Apology to my people in ortho. And those of us that are neuro, we can spend up to 2 hours 2.5 hours. The pediatrics one on math. But for the sake of our environment, so that patients will not be chased away, my HOD and the management have kept the price the same for all categories of patients. But as a neuro patient, a neuro person, I'm into neuro physiotherapy. That's where I got my director from. So please, we always advocate that, so that they can, because the unit, the amount you make determine in terms of what you want to get from us when we are doing our budgeting. We have our IGR. The physiotherapy department IGR is separate, and we always advocate to them that most of the time, unlike lab, unlike radiology, whereby they will buy them consumables in terms of reagents, in terms of radiographic film. Physiotherapy, all our money, they are all profits. So, and we argue that, and they separate our purse from hospital IGR, so that when we and we distribute it to encourage unit, though still auto is the most is the one that get more money. But neuro, we are close to them. Sometimes it will be auto, sometimes it will be neuro, and we encourage. So each unit encourage themselves, so that when we see the IGR, because hospital, though they value standard of practice, but when you get to admin, when you get to management meeting, as much as you are making requests, you are doing your budgeting, the CMD will be looking at the IGR. That's what is important to him most, to justify whatever they want. But sometimes we do argue and make them to see that IGR alone should not be a major factor for determining what they will provide for us. To it must be according to MRTB policy and regulations. We always argue that.
Thank you so much. So this is helpful. So in a sense, in public health, we have some ways or some mechanisms for costing how much a service how much a service costs, or a particular activity. So I know we've not done that in Nigeria, I mean, in a very methodological way. So when we are costing for services, take for instance, I mean, you alluded to some of them. Like in the work I do, let me give you an example. So we have a project from which we are implementing from Bill Gates Foundation, or we just got one. Like we just got a project from Gavi. Gavi is the Vaccine Alliance. So is a global organization that is set up to mobilize money from philanthropies, from governments, to support immunization services in countries where there's a huge burden of vaccine-preventable diseases. So now, the money how we arrive at, okay, for us to provide this service, there is a template for costing services, like budget. So we look at what we call level of effort, LOE. So let me explain. So if I'm to treat a patient who is maybe has a particular disease condition, let's say maybe osteoarthritis. So we may need to ask, okay, for instance, how much effort in terms of maybe hours will it take me to treat a patient? So for a condition that will require like 1 hour for me to provide at least optimal treatment section, then there should be an amount. So, and the labor costs are different. So if, for instance, a junior physiotherapist, like entry level, is treating a patient, the cost should not be the same if an associate director or a very senior physiotherapist is treating, because you cannot be charging the same. I'm just saying, I'm not arguing or contesting the way it's done, but I'm just talking in an ideal world. Let me give you an example. if we are budgeting for a program, if somebody is a junior team member, the amount, because it speaks to value, the amount that it will cost for me to treat or provide a particular service cannot be the same for someone else who doesn't have as much experience or expertise like I do. So you could see that. So that also influences how much we are to charge a patient. I'm just, if we, for instance, have like a clear-cut system for billing or a clear-cut system for costing or budgeting, how much it will take. It doesn't matter if government is going to subsidize, but in the ideal sense. So we should have like, at some point, I'm saying this is why when we are able, as part of the planning for rehab services, to understand a bit of that. So if I'm doing a consultancy, before my present job, at some point I did some independent consultancy. So if I have a consultancy rate, let me give you an example. I have done some jobs where for a day, like maybe the work will involve 20 working days or what we call LOE. For each day, there is an amount I charge as my fee. And to be frank, I have done jobs where I'm paid $500 per day as my consultancy fee. But somebody who doesn't have as much experience as I am might be charging, the organization might negotiate it down, so maybe $200 or $100, or it could be in Naira. So I'm just giving this as a general way that, yes, so I'm trying to collaborate what you're saying, that we are undercharging, for sure. But it's just that we don't have a uniform framework for charging rehabilitation services. So for a lot of professionals, like if an architect, the Nigerian Institute for Estate Surveyors, please can somebody, please can we mute the person? So there is, anyway, let me just quickly, I think I'm looking at the time is almost 2:30. So I want to rush so that we don't spend the whole day here. So in a sense, how to buy, so we talk about contractual agreement. So in purchasing, so there is supposed to be what we call service level agreements, SLA. So if one is to provide this service, this is how much it will cost, and this is how much you are entitled to. So it's clear in a contract. So when health insurance people are contracting hospitals, so there is what we call provider payment mechanisms. So you are paying to a provider of a service. So under health insurance, we have two common provider payment mechanisms we use in Nigeria. The first is called capitation. So capitation is like per capita, so per head. So under the national health insurance, for those who are working in government, so maybe let's say Ministry of Health or a particular teaching hospital. So the staff are under a particular HMO, and then that HMO will allocate you to specific hospitals. So if the National Health Insurance Scheme, NHIA, allocated, let's say, 500 lives, we use the word life, so the people who are enrolled under the scheme, so maybe the husband, the wife, and children, so each person is called a life. So the number of lives that NHIA allocates to an HMO, so the HMO will distribute that to different hospitals. Now, under primary care, that's like first level of care, first contact. So the HMOs are paid per capita, that's capitation. So 500 people, they have like a particular fee. So for primary care, we are paying $750 for each person. And it's whether they go to hospital or not within that time period. So the HMO will retain that money and pay to, or you get that money and then pay for primary healthcare. Then for referral, like secondary or tertiary, is paid through what we call fee for service. So for physiotherapy, for occupational therapy, for all the specialist care, it is true if the surgery, they're all called under fee for service. So just two payment mechanisms, capitation and fee for service. In Nigeria, but in other countries, there are also some modifications, which I don't need to go into. Then who to buy from, which facility. So for rehabilitation, currently, we are not really providing rehabilitation at the primary healthcare level. Mainly, the facilities are mainly secondary and tertiary. I don't know, and the push is how do we get to make rehabilitation services available at the primary healthcare level? What will it require? So that growaway and the service availability and readiness assessment are things that we can modify or adapt to prepare for such. And then, like I said, what to buy. So what to buy is what we call the benefit package. So if you have health insurance, the services that you are entitled to under that policy is what is called the benefit package. So if somebody is signed on to the health insurance, there are exclusions that, so maybe under this health insurance, we will pay for this, but we will not pay for this. So for instance, for rehabilitation, they pegged it at, so maybe a specific number of visits, and then they cap it there. So those are determined benefit package, as we say. So benefit package is the services that each enrollee is entitled. So for rehabilitation, unfortunately, within the National Health Insurance Scheme, the early days, as in the first guideline that was developed like 15, 20 years ago, did not include much of rehabilitation services. So, but earlier this year, so NHIA started a process to review the tariff. That's how much it pays for each service. And good thing was that MRTB and NSP really worked together. So I kind of facilitated the participation, and we were able to, some representatives in Abuja were able to participate in that program, where we made sure that a comprehensive list of rehabilitation services were submitted to the Health Insurance Agency for their consideration as they review the benefits package. So these are some developments that we hope they adopt them so that we have more rehabilitation services included in the health insurance, and also the tariff that is paid. So part of the data that the rehabilitation team collected were, for instance, they did a mapping of how much for different services are being paid for in different locations and in different facilities, both public and private, the physiotherapy or rehabilitation service providers. So that data was collected, which is similar to what when we are talking about market analysis. So I'm hoping that we will continue to engage, because we were not part of the first phase of developing the National Health Insurance Scheme, and that impacted negatively on rehabilitation services inclusion in the benefit package. So I may not have to go so deep into this, but this is a framework that my organization had developed back in, I think, like a year or two ago for WHO. So we worked with WHO to develop the financing, how rehabilitation can be financed. So we developed that guideline. So it's called the rehabilitation financing. I can share that report for those who are interested. So it looked at the different types of, so in the middle, if you look, so all the other things we had been discussing about rehabilitation, service availability and readiness assessment, human resource, the growaway, they are all on the left column here. So you're looking at, sorry, somebody's drawing lines over here. It's okay. So, but if you look at the middle one, outcomes in rehabilitation financing, prepaid pools, risk subsidization, efficiency, incentives. Anyway, I don't want to, it's not a head financing class, but just to give you an idea of the different things to keep it in consideration when we are to discuss how best to finance rehabilitation services. So we already have a framework that was developed by my organization for WHO, and hopefully countries can adapt and use it to improve how rehabilitation services are financed. And I think, okay. So let me stop there in case people have questions with respect to financing before I think we are almost on the last one. So let me pause here for questions around financing. Any questions? Okay, since there is no question, maybe one just last word with respect to financing. So to cost a service, to actually find what's the real value of a service, so we need to do a costing. So you have like a costing model. Now to cost, so it's not here in the slide, but we have what we call the direct cost and indirect cost. So first of all, to what we need to include in the costing, what we call the fixed cost. So fixed cost looks at especially things like infrastructure. So how much will it take, for instance, like a building? So we may have a physiotherapy department or occupational therapy department, or maybe a rehabilitation center that accommodates everybody. So how much is the cost of that building, that fixed asset? So you know that an asset will have like a value. So maybe it can depreciate or increase over time, but it's important to know how much that cost, because it's part of what is built into the costing of a particular service. So if someone, for instance, rents an expensive maybe facility building, the rent is high. So the rent is part of the costing. So need to make sure that, okay, the overhead is also included. You also need to include, for instance, the human resource, like I said before. So if a junior staff is to provide a service, the cost of providing that service will not be the same if it is a senior professional. So the cost variation is there. And then we also need to do in the costing, take into consideration several other elements. For instance, what we call the operational cost. So what does it take to run like a clinic or a facility or a department on a daily basis? So if I am the HOD of a physiotherapy department, I need to know how much what we call like the minimal operational cost. So you have electricity, you have water that is needed for running a facility. You have other infrastructure like the spleen, the beds, the chairs, a whole lot of other things. So those costs, there's a way when we are doing costing that all those cost elements are populated to help arrive at the actual cost of a particular service. So because we have not developed capacity or have that skill or knowledge to this kind of costing, so we can maybe use whatever, I'm using the word arbitrary, not in a negative sense. It's okay. Like my colleague who said, okay, consultation fee for everybody is 1.5. So you asked, okay, what criteria did we use to determine how much is the consultation fee? But in private sector, because not just because they are profit driven, they want to make sure that their operational cost is at a minimum so that they can maximize profit. So they want to make sure that there are no redundancies in the way they are costing. So they cost every element. So I've done some work or been involved in some work where you do costing. It's quite an extensive thing. So we may get to a point, either the board might work with the professional groups, and we can get some professionals who, as in experts in costing. So there are people who are experts in costing that can help to budget for us, to have a fair idea of at least the market value of the services we are providing. So with that kind of understanding or having that kind of evidence, then like my colleague who also some of the engagement with the senior management of the hospitals, whether CMAC or the CMD, if they understand the actual value, the market value of the services we are providing, then they will know that, oh, that the hospital is subsidizing this amount. So in reality, the cumulative funds we are generating is much more than we are reporting, because we are the costing of the services, we are under costing the services we are providing. So that's just in a nutshell. So I think we may need to, at some point, maybe together with the board, think of maybe running a separate course on how to cost health services. Is an entirely interesting area, just to open our eyes to see that, oh, that we're actually providing much more value than is being recorded. So I was just explaining that just to wait in case anybody has any question. Otherwise, we'll go to the last bit for today, which is, I just want to talk about logistics, supply chain. So before we go there, let me go back. So do we know what is logistics and supply chain management? Just anybody who understands, pretty much just brief. So within public health, logistics and supply chain is a key aspect of the program. So almost every public health program will have like a supply chain or logistics component of the program. Please, anyone who understands logistics. So we have logistics companies. So just from our society, we know about logistics. So we have companies that are called logistics companies. And also, what do they do? And it will be helpful. Then we can apply it to rehabilitation. That's just the point. Hello? There's silence in the house. Please, anyone, just feel free. What do you understand by logistics and supply chain? Someone should save me, please. Anyone, please, you can unmute yourself and speak. There's no right or wrong answer.
Good afternoon, sir.
Good afternoon. Please go ahead.
It's a question that I have. You said if anybody has a question, I was trying
please
to
go
unmute
ahead.
myself.
Yeah, it doesn't matter. Yeah, please ask.
Okay. You were talking about professional value in terms of costing or in terms of generating resources. My question is, if we are going to go by the number of years someone has served, whether it's a consultant, a doctor physiotherapist, or a junior physiotherapist. If we're going to use that to rate what a patient is going to pay for his services, is there going to be like a minimum value? Is it going to be also like regulated by the therapist board, or it depends on different facility organization? How would that be feasible? That's in Nigeria now, to actually generate revenue from that kind of policy. What will be the implications, sir?
Okay, thank you. Just a caveat. So it was just illustrative. So I use it as an illustration. So, and it's not as if it's something that is not happening within our health sector. So if you go to a private clinic to see a doctor, if it's an MO, medical officer, or a senior house officer, the amount the hospital will charge you, I'm talking of private hospital now, the amount they will charge for services provided by a medical officer or a senior house officer will not be the same amount if the person that you are consulting is a consultant, for instance. So consultants will charge more for their consultation compared to if it was a general physician or a family physician that sees a patient at a hospital. So I use that as an example. So I say, okay, if it is happening already within the health sector, so within rehabilitation, would it not make sense that if for someone who has experience, who is a specialist in, say, for instance, neurophysiotherapy or musculoskeletal expert that is treating a low back pain patient compared to a junior team member who doesn't have as much experience or clinical competency or expertise. So I'm just saying that is in reality, the value they are providing is not the same. So the economic value or the cost of such should be relative as well. I'm just saying it doesn't necessarily mean that patients are to be charged that as a policy, but I'm trying to say if we are to value or estimate the value or the cost for the services we are providing, I was trying to use that as an example that we are, like what we are charging obviously is not at par with the value or the actual cost of the services we are providing. So if we are even subsidizing, so someone pays 1.5, what is the subsidy? So you are subsidizing if, for instance, the actual value is 5,000 and then you are charging 1.5. That means the subsidy is like 2.5 or thereabout, or 3.5 actually. So that's the point I was making. So, okay, that costing, having a methodology for costing rehabilitation services will give us a fair idea or a fair number of what the market value of that service is, even though we are charging a subsidized rate. So that's the point I'm making in terms of economics and costing. So if I go to a market and the actual market value of a particular product is, say, 10,000, then I say, oh, can you give me a discount? So discount is a form of subsidy. So the person says, okay, I'll give you 20% discount or 50% discount. So that is to say, okay, the actual value is this, but I'm subsidizing X amount for you. So it does not reduce the value of that product or service, even though what is being paid is not at the market value. So that's the point I'm trying to make, because that way, if we come to a point where it's okay, what is the actual cost of treating a patient with this condition at the market rate? So a market rate is, even though yes, at the public hospital, we know it's subsidized, but if we say the subsidy, how much is the subsidy? And we can't know the amount of subsidy or the percentage of discount we are providing if, for instance, we have not determined how much is the actual cost of a particular service. So for instance, when we do costing, so we also take into consideration, let's say for instance, the cost of services provided last year cannot be the same as it is this year because inflation has happened, there is devaluation of Naira and all. So when we are doing costing, we also make provisions for depreciation in terms of the currency. We also make provisions for adjusted values because of inflation. So I'm just trying to say costing is a entirely different ball game. So it's something that maybe as a profession or as a professional group or with the support of the board, at some point, we may need to have a framework for. Why I'm saying this is that every strategic plan is costed. So when we are able to develop a strategic plan for rehabilitation, then there are principles of costing and how costing is done would have to be used to determine how much is needed to provide the type of services that are covered under rehabilitation. So let me give you an example. The health plan that Dr. Pate is leading. So the plan has been developed. Just last month, we supported the Ministry of Health, the National Health Insurance Agency, and also planning to support, even Lagos State, yeah. We supported Lagos State to develop what we call the annual operational plan, and then to cost how much it would take to provide services included in that plan. So at the moment, I'm not sure rehabilitation services were included in the strategic plan of any state or at the national. But if we were to say, okay, rehabilitation services for this number of people in our population, how do we arrive at the cost? So there has to be a mechanism, a standardized approach or methodology for costing rehabilitation services. That's just the point I'm making in general. I hope you got I hope my answer responded to your question. Any other question before we go to this last one? I know I want us to at least finish by 3:30 latest. Okay, great. Thank you, Ochai. Okay, so for today, I know it's been a long day since 10 o'clock. It's already what time is it now? It's almost 3 o'clock. This is 12 minutes to 3. Let's just quickly wrap up with logistics and supply chain. So for any health service or for any program or population level program or even individual, so logistics and supply chain speaks to what is that framework? What's that mechanism for you to procure and supply all the essential medicines here and all the products we need to deliver a particular program. So for instance, if we are running a malaria control program, so procurement and supply chain speaks to how do we procure? Procure means how do we buy or we get or all that we require for the work we are going to do or for the program we are going to deliver. So with respect to rehabilitation, for instance, so we ask ourselves, how do we procure and supply all the materials, equipment, and facilities that we need to deliver rehabilitation services, the different types of rehabilitation services? So if in a hospital we are to establish a rehabilitation that is a general, not specific to any type of rehabilitation area, but we have a rehabilitation center. So how do we procure all the equipment, all the facilities that we need in that gym? So that process, how do we even determine how much we need in terms of number, for instance, of, let's say we want to buy a particular equipment, what data, what process do we need to develop a plan for getting those things. So do we need to import? If we are to import and all of that. So let me give you an example. So for Nigeria, let's give you an example of immunization. So for every immunization program, we want to ask ourselves, how many children do we want to immunize? Let's say 1 million of children between age 0 and 5. That's under 5 children who need to be immunized either against polio. So let me use polio as an example. So we now need to do what we call quantification. We want to like put numbers. It's okay, we will need this X number of vaccines in terms of vials, like each vial of vaccine. How many do we need to buy? So if each child needs like 2 or 3 drops, you know, so all those quantification, that's like arriving at the number that you want to buy. So if it is drugs in a hospital, like pharmacists are very good with issues around procurement and quantification of drugs. So they look at their inventory. So they have an idea of how many patients, they say how many paracetamol did we dispense in a day? And then you do like for a week, for instance. So to ensure that I don't run out of stock, so they constantly are quantifying and forecasting what they need. So for every program, we need to forecast and quantify for each element, for each commodity, for each equipment, how much in terms of numbers do we need, and then how much is the unit cost, and then it will help us arrive at the cost of providing a particular service. So that's just what supply chain. So for immunization, we have a supply chain system. Just to give you, I mean, this is not so much about rehabilitation now. So within the national supply chain and procurement system, we have what we call the central medical stores. So we have one in Lagos, is at Oshodi. Then we also have one in Abuja. So most of the commodities that we need for public health programs or mass programs, whether it is for malaria, for instance. So we have the ACTs, so they will bring them and then deposit at the central medical stores. Then from the central medical stores, it goes to the states. So states have what they call state medical stores. So they have the national one. And then from the states, health facilities go there to collect their own. But in recent years, we at the National Council on Health, about 5 or 6 years ago, there was an approval that states can set up their own what they call drug management agencies, DMAs. So these DMAs now help states to procure all the essential. So we have what we call the essential medicines list. So every country will have their own essential medicines list where for all the common conditions or diseases or ailments in that country. So what are the regular drugs? So for instance, Nigeria, malaria is a big burden. So we now say, okay, how many people will need malaria, anti-malaria drugs? Or for maybe places where they have the test kits, how many test kits do you need? Or if it's for HIV/AIDS, the same thing. So how many antiretroviral drugs for how many number of HIV/AIDS positive patients? So this is what supply chain is about. So for us, let's say in rehabilitation, so we ask ourselves, okay, for the patients we see, the number, the volume, what type of materials do we need? What kind of consumables? I mean, we don't use so much of consumables as much compared to, say, people that work in the lab. But notwithstanding, the things that we need, so they need to be quantified and then put a price on them. So this is pretty much what logistics and supply chain. So there are much more detailed things about it, but it just gives you an idea, like, how do I make sure that everything I need for providing a particular service is available at the time it is needed, and you don't experience what we call stock out. So, and in supply chain, it can be like what we call push or pull. Push is like where let's say the central procurement agency, maybe like say every month will send a particular quantity of a drug or reagents or commodities to a health facility, irrespective of what their needs are. So that is called push. But pull system is a little bit better because it's based on the fact that I request based on my needs. So it might vary. For instance, either in a month, we have more specific type of patients that come. What do they need? Then I make sure, because of the projection, I've projected the number of patients that will require a particular service and what is needed. Then I order that and stuff. So in some hospitals, I don't know if we have heard about DRF, Drug Revolving Fund. So in some places, to ensure that health facilities have enough money to be procuring the drugs that patients need in their facilities. So they set up what we call Drug Revolving Fund, DRF, where they have a seed stock of money. I mean, they have a pool of money they use to procure drugs, and then they sell to patients, and then constantly replenish to make sure that they don't run out of specific drugs that they need. So to avoid stock out. So there is a financing mechanism called DRF that has been used in different countries, even in Nigeria as well, to cover health commodities. So in Nigeria, we have what we call the National Health Logistics Management Information System, which is a system for keeping an inventory of all the quantification, all of that. So there's an electronic system that is warehoused within the Ministry of Health and is under the Department of Food and Drugs. So you have more pharmacies there. So most of the supply of commodities, health commodities in Nigeria is managed through that system. Now, just the final one, I wanted to bring us, so for rehabilitation, yes, we don't procure drugs as in pills and all. I know that for physiotherapy, possibly there are specific topical analgesics that we do use and stuff. So maybe that may be just about drugs, but most of the things we need are modalities and equipment for providing rehabilitation services. So in 2022, the Federal Ministry of Health, in collaboration with the National Commission on Persons with Disability and several others, developed what we call the National Priority Assistive Products List, APL. So this is of importance to us as rehabilitation experts and practitioners, that there is actually a policy document that outlines every type of equipment or device, broadly speaking, that we require to provide if we are planning for rehabilitation services. So as rehabilitation is gaining global attention within global health, or what we call universal health coverage agenda, so there are two sides to it. So we have the provision of rehabilitation services in one, and then the complementary side is the provision of assistive devices. Sorry, so what you see there, WHO stroke AT 2030. So as we have rehabilitation 2030, we also have the assistive devices 2030 agenda or goal. And the goal is to reach 500 million people globally, like providing access to assistive devices by 2030. So just like we have rehabilitation 2030 agenda, we also have a complementary assistive devices 2030 agenda. And interestingly, there is a lot of money that has been earmarked for providing assistive devices. Just sometime last year, there is an organization at the global level, just like we have Gavi that is providing funding for immunizations and vaccine. Global Fund is a mechanism for funding programs in HIV/AIDS, TB, and malaria. So Global Fund for AIDS, TB, and malaria. So we have a similar organization within the United Nations or WHO that is called AT at scale. That's assistive devices at scale. So just help implement the WHO assistive devices 2030 agenda. So they received money from a couple of donors and have been providing some support to different countries. So it's important for us to keep this in mind. So this National Priority Assistive Product List for rehabilitation, the idea is, let me just read, it says, so one of the key things, assistive devices or assistive technology, as it is to devices that help or improve the ability of persons with disabilities to participate in education, employment, and live independent and dignified life. And that is the ultimate goal of rehabilitation, improved function and independent living. So assistive technology or assistive devices is an umbrella term covering the systems and services related to the delivery of assistive products. So I don't want, because I know it's been a long day, so I didn't want to go into so much details, but this policy or this document that the ministry published in 2022, it has a comprehensive list of all the different types of assistive devices that rehabilitation professionals need or can provide to persons who need them. I know when I was, for most of us, so the assistive devices we know mainly for mobility, maybe crutches or wheelchair, but there are a lot more. So the last bullet on this slide, so within that policy document, so it has a long list of mobility of, so devices that aid mobility. So a long list. So where you have all the crutches, the wheelchairs, and several other things. And then for our colleagues who are experts in audiology and speech therapy, so they also have a long list of different equipment and devices for improving hearing and communication. So for those who have impairment with respect to hearing and communication, so they have a long list. Then for the visually impaired, they also have a long list of the different types of devices that can be used, that can be provided for those who have visual impairment. The same for cognition, for those who have developmental challenges. So they also have different, so for instance, for people who have loss of vision, you notice that even technology has become so interactive through virtual reality that someone who is blind can actually use their phone, because a lot of phones have accessibility functionalities. So for somebody who cannot see, maybe their laptop or their phone will have some audio capabilities whereby they can understand things that are being said, even if they are not hearing, because either braille or they have some touch related things they can do. So if you notice, technology is evolving, and with AI, you realize that some of these impairments, technology is breaching that gap, making it easy for people who have such disabilities or impairments to experience life almost near normal. The same for self-care. So to take care of oneself, there are That's to aid activities of daily living or independent living. They also have a lot of lists for under self-care. So I only just pulled out these categories to just let us know that within rehabilitation, we have actually a long list of devices that can be procured, and there are mechanisms at the global level to procure such. For instance, last year, this 80 at scale had reached out to Federal Ministry of Health to request for support to provide reading glasses and hearing aids for a certain number of Nigerians. So they made a bid, like called for proposals or bid. And I know there are a few organizations who are working within this space, like Sight Savers, the Clinton Health Foundation, in a sense, Clinton Health Associates. So there are a couple of organizations that are currently supporting or working in this area of procuring and supplying assistive devices for rehabilitation purposes. I think that's all for me from now. I mean, I managed to cover some things that the other facilitator is not here, but at least I tried to, okay, let me touch some of these areas. We might be able to have like a follow-on, maybe to dive deep into some of these areas. But for now, I just feel so that we are not overloaded, I think I can stop here for today. And then we can, if we have questions, we can take the next, because I want us to finish here before 3:30. I don't want it to be the whole day, but we can discuss generally. Let's chat for the next 10, 15, 20 minutes as possible. Thank you. Yes, the reading materials, yes, I'm collecting them. So what I wanted to do is that for the different topics we had covered, for instance, we started with public health and epidemiological transition. So I will put some reading materials at the end of that. So I will it's something I will do to update the slide so that we have better understanding. Some of the, for instance, I told you about the Global Burden of Disease study, which was published this year. So I will include a link on that so that people can read to see what it is. It's very interactive. It has visual data visualization properties. So you can, very interactive. You can just see what the burden is for Nigeria, for stroke, for anything. You just push out the figures for you. Then for the service availability and readiness assessment, I will share the WHO framework, and then also the one for rehab, the GROWE. So for all the different things, then for rehabilitation financing, I will also share the report that my organization had developed for WHO on rehabilitation financing. It may sound a bit technical for some people, but it's just a resource, a reference resource. The same for the human resources aspect. So I will share the human resources policy that the government had developed so that we see how a policy is structured, the process, because the process of developing a policy is usually included in the policy document, how the process is. So the steps, the analysis that was done or assessment, and then how they define the priority areas and then the implementation plan. So I will include all of that in like a reading, like a reference list for at the end of each of these topical areas. Thank you.
Thank you so much, sir, for the time spent, the knowledge imparted. We are grateful. And now it's time for questions. Please, if anyone has any question, you can kindly raise your virtual hand or you're mute and ask while we wait. Thank you.
I mean, it doesn't have to be question. It can also be contribution. Are there some insights that, or some things you think we can discuss generally? I think it's fine. I will also include my email address and yeah, my email address. Okay, I didn't include my number. Maybe I will do that, but this is my email address, and also this is my LinkedIn page in case you want to connect with me. I know we have like
just
100
giving more examples. Eka, do you now follow? Eka, you sent a message that you did not understand. Yeah. See better? Yes, yes. Okay. Okay, so let's look at the clips. Let's now look at the clips and see what examples we have.
Sorry, I didn't get what you said. Hello, someone was speaking, but it's like we lost her. Yeah, so I mean, I was intentional while I pivoted towards public health and more population level work, because I know that we are all familiar with the clinical side in terms of the day-to-day individual, like how to treat a specific patient. But I just feel that I know because of the work we do, we are often not familiar or very conversant with more broad health services or health systems things. So that's why I use more like a health systems and policy approach so that we see beyond the clinical side of things we are doing and how what we are doing at the clinical side feeds into or relate to broader health agenda, health system and all, because it's important that we are conversant with and involved and engaged in what is happening at that level. So please feel free. You can hit me on LinkedIn and then drop a message. If you have any question that you don't have the time to ask today, please shoot me an email. My email is there, obifelix@gmail.com. And if you're interested in knowing more about, or you're thinking about global health, public health, you have questions, please feel free to reach out and I'll be able to support. So, Madam, over to you. It looks like we don't have any more questions.
Okay, sir. In the absence of no questions or contribution, I think we can call it a day. Thank you so much, everybody, for your time. Timothy, please, do you have any? Okay. I think we're in error. Okay. So I think we can call it a day. Thank you very much, everybody. Thank you, sir. We're grateful.
Yeah, let me show my face again in case, just to say bye. It was really a pleasure. Hopefully we'll get to have a face-to-face section. I know that sometimes face-to-face sections, you have more opportunity to interact. But thank you everyone for hanging in there. And I will send Madam, I'll coordinate with Madam from MRTV too. Once I will update the slides and include the references and all of that, including the Disability Act and all of those important aspects that we touched today. Thank you. Over to you, Madam.
Thank you, sir. I think we've called it a day.
Yes.
All right, sir. Thank you, sir.
Okay, bye, everyone.